So we're going to start the class, that is the Cardiology 3, and we have very important topic today. I would like to welcome Dr. Raghavati from India and Dr. Nishanta from Sri Lanka. I really welcome you here, Doctor Academy, and I hope that it will be a very helpful and fruitful journey of you guys with us. And definitely we'll pass the part on MRCP part on with very handsome number. Anyway, as I have been saying, that cardiology is one of the most important topics you need to encounter in MRCP part on. So as today we're going to talk on the third class regarding this cardiology, and we have some important topic today. Okay, we have some important topic today. So I always, what I do say, that you have to give your 100% whenever you are going to participate in any sort of exam. Okay, you have to give your 100%, not 5%, not 10%, not 60%. You have to give your 100%. You have to be very serious whenever you're going for any exam. Okay, you have to be very, very serious regarding any sort of exam. It's not like that, let us try once, let us give a try. No, it's not like that. So in every sort of exam, you have to give your 100%, and you need to assess yourself before going into the exam hall. So how you can assess yourself? The best way that you can assess yourself, that is giving the mock timely. You shouldn't take enough time to appear the mock. If you think that one system has been closed, one system has been finished, so it's your high time to sit for the mock exam or to sit for the exam. And whenever you're going through the question bank, particularly if you're struggling with the on exam, it's okay. But if you're struggling with the past test, it does mean that you're not even polished candidate. Without being a polished candidate, you shouldn't go for the exam. That's a very clear-cut statement from us. Okay, because somehow if you're suppose somehow you're going to pass the MRCP part 1, but believe me, there in MRCP part 2, you are going to face a lot of problem. And over there in PACES exam, oh my god, that's a totally different thing. That's a totally different thing. How many degrees already you have in your hands, that doesn't even matter in PACES. PACES is totally a different exam, different matter, different examination procedure, different differentials you need to say. Like the first thing what I need to say regarding this class, suppose a patient has come to you with the problem with the hand pain. Okay, simply hand pain, and this is a real case. It's not like that I'm saying this is a real case of MRCP part 1, part 2, even in patients. The same scenario. They usually try to give the same. I mean the scenario from the RCP, and the reason why they are giving this question there in MRCP part 1, they're in MRCP part 2, or even they're in patients. So what's that? A patient came to with simply hand pain. Which hand? Suppose either left hand or even right hand. So if you do think that the patient has come to you with the features of hand pain, just simply hand pain, nothing else. So from this prompt only, just tell me 5 to 6 differentials. Anyone? I will appreciate your answer, definitely. What do you think? A patient has come to you with simply hand pain. Of course, the patient has other so many features, but I'm not going to say or I'm not going to reveal all of those. I'm just giving you the patient is having hand pain. Now tell me your differentials regarding hand pain. How will you evaluate the patient? What do you think? What do you think that this might be the reasons why the patient is having hand pain? What do you think? Dr. Anand sir, are you there?
Yes, sir. I am here. Preferred
Sir,
preferred pain of ischemia, myocardial ischemia.
Sir, you can say anything whatever you want regarding hand pain. Suppose a patient is having hand pain, the right hand, the patient is feeling hand pain for a particular time, right? Like 1.5 months, patient having hand pain. So what is the first thing what you need to evaluate? Whether this is from the rheumatology section, right? So hand pain in exam scenario, if you think the patient is coming up with the hand pain, even asymmetrical, even unilateral, though you have to rule out whether this is any sort of inflammatory arthritis or not. Okay, I mean whether this is RA, whether this is psoriatic arthropathy, whether this is osteoarthropathy, whether this is a case of simply SLE or not. So this is how you are going to evaluate. Well, so no rheumatological association you have found, no rheumatological association are found, then what do you need to look for? That any association or any interconnection in between the rheumatological disease, like the Raynaud's. Raynaud's simply come up with the features of hand pain at first. After that, the color changes, it begins. So if simply the patient is coming with the hand pain, so you have to look for, you have to rule out the Raynaud's itself as well. Okay, sometimes the primary Raynaud's will come up with having no other features of any other rheumatological association. That's a very good question for MRCP pardon. So now, if you think the rheumatological association, all the association, I have excluded them. Right now, at that moment, you have got another clue. That was that the patient has a history of gaining weight for the last 6 months. Okay, for the last 6 months, the patient is gaining weight. Now, can you tell me what is the reason behind this hand pain? Just by simple this prompt, no other info. Anyone? Dr. Answer, what do you think? Simply try. The patient is gaining weight. Yes, I know. You might think that, yeah, with only this limited info, can we make a diagnosis? But yes, here in MRCP, you need to make it possible. So whenever you do think there is something like gaining weight in your question or in your info, in your prompt over there in paces. So if you do think there's something like gaining weight, so it does mean the patient might be having carpal tunnel syndrome. Okay, so the hand pain is due to mainly carpal tunnel syndrome. Okay, now no other problems like this. Even there is nothing like weight gain, rather there are history of weight loss. There are history of weight loss. Now the patient is having hand pain. So what do you think? The next talk. What do you think? No? Of course, again back to the rheumatology association, but I have excluded all of them. So no rheumatology so far. Again, we have to exclude other thing like any vascular issue might be there. Okay, any vascular issue might be there. What's that? That is the Takayasu's arteritis. And yes, today our topic is Takayasu's arteritis because we are going through the cardiology system. So whenever there is something like hand pain, at first you need to rule out the rheumatological issues. Might be a case of RA, might be a case of SLE, might be a case of simply psoriatic arthritis, even without having any sort of psoriatic rashes, as you know, it's possible, even possible. And then you have to rule out the other thing, like simply it might be a case of the osteoarthritis. Okay. Then you have to rule out the other nervous nervous system issue like the carpal tunnel syndrome. So of course you need to rule out whether this is a case of carpal tunnel syndrome or not. So if you do think, yeah, there is a typical history, so of course it will be easier for you to make the diagnosis of the carpal tunnel syndrome. But yeah, no, you shouldn't expect every time they will give you the typical data like the patient feels no pain or a patient gets some sort of relief whenever he or she is trying to shake the hand. No, not every time you're going to have this kind of typical information. Remember, not every time. Even there might be no typical diurnal variation or even the night symptoms. No, might not be present over there. Again, sometimes carpal tunnel syndrome will be your diagnosis, but there will be info or there will be data regarding there will be data given there will be given to you regarding the rheumatoid arthritis. So again, be sure that having data or having info regarding rheumatoid arthritis doesn't mean that this hand pain at this moment is due to mainly again for rheumatoid arthritis. No, this hand pain due to mainly carpal tunnel syndrome, though the patient is a diagnosed case of RA. So sometimes you have to use your brain. Sometimes you have to use your residual knowledge. So if you're not able to make your residual knowledge, if you're not able to enhance your residual knowledge, then it will be a very tough exam for you. So that is why I'm saying again and again that you have to gather so much information that is associated or related with MRCP pattern, not with any other exam format, any other exam format. Okay, this is how, because Not necessarily in your local exam, you are making the diagnosis of Takayasu arteritis by simply the hand pain prompt. No, I think it's not even possible. But over there in UK, over there in the exam of the RCP, like the MRCP part on MRCP PACES, and most importantly in PACES exam, so many times you need to make the diagnosis of the Takayasu or the large vessel vasculitis just by having this simple info. What's that? The patient is having hand pain, simply hand pain. Whenever you are going through the details, the patient is saying, yeah, this is the hand pain. The character of the hand pain is something like the intermittent claudication. Okay, so now you know that in case of Takayasu arteritis, intermittent claudication or claudicating pain is very common. Yeah, the reason why this is something like the vasculitis. So as we're discussing regarding the Takayasu arteritis, why I'm saying this, in 2023, it was the most important question regarding any sort of vasculitis. Previously, we used to know that, yeah, vasculitis like the Weisner's granulomatosis is very important for MRC powder, but right now at this moment, they are giving so much question regarding the large vessel vasculitis, because this is very common, and particularly here in Asia, this is a very common case. This is a very common case. One of the common cases, regarding the vasculitis issue. So you need to know each and everything regarding the Takayasu vasculitis. So the number one thing that I have said, that the patient might have some hand pain issue. The number two issue. So there will be, as I'm saying, they will try to give you some data regarding this. So the next data that you should expect, that is intermittent claudication. Might be hand pain, might be also leg pain. Okay, so intermittent claudication, the another thing. Number three, that would be very easier for you if you are getting this data. What is that? That is, they're saying the patient has absent pulse on the right hand or even in the left hand. I mean the hand where the patient is having pain. So if they are saying the patient is having absent pulse, so again you have to think regarding the Takayasu vasculitis. Then of course the blood pressure, that would be unequal in between the hands, or as you know. Okay, sometimes even might not be possible to elicit the blood pressure. So then another data what you need to know, that is that in case of any sort of vasculitis, there should be some sort of constitutional symptoms, like might be fever, might weight loss, might be there some history of malaise, particularly malaise. They try to give this data in pardon, particularly not the fever, not the weight loss, but particularly the malaise they try to give you. So if you do think, yeah, there is something like malaise, so then again you have to rule out the vasculitis whenever the patient is coming with the hand pain issue, particularly the unilateral hand pain issue. Okay, so now the next thing what you need to know, what are the precordium findings? Well, again I'm saying regarding the MRCP exam, regarding the MRCP, not the practical orientation, regarding the MRCP exam, if you think the patient is having Takayasu arteritis, that is high likely they will try to give you a data regarding a murmur, which is early diastolic murmur. Okay, so what's that? There's the murmur of the aortic regurgitation. So regarding the MRCP pardon, not I'm saying regarding the PACES, because in PACES I have never seen patients of Takayasu arteritis, they are having murmur like AR, I mean aortic regurgitation. So practically it's not that much common, but whenever you're trying for the MRCP pardon exam, AR is very common with Takayasu arteritis. Okay, AR is very common. So in echo finding, might be a AR is present, or they're saying on precordium examination there is an early diastolic murmur. So they are giving the clue, yeah, this murmur is something like that, aortic regurgitation. So another thing, the patient is also having hypertension. The patient is also having hypertension. Now we can say, yeah, patients with vasculitis, they're high likely to develop hypertension, because hypertension has some secondary causes and vasculitis is one of them. Okay, that's fine. But whenever a patient, particularly with Takayasu arteritis, is having hypertension, you have to rule out the ... Can you tell me what's that? Anyone? You can simply try. You can try your residual knowledge. Don't worry. What's that, sir?
Renal involvement.
Renal?
Renal involvement. Renal.
What's that?
Kidney.
Okay. So what's that involvement? Is it CKD or something like anything? Is it GN or any other thing? Why hypertension? Right now at this moment we are all everybody the postgrad candidates, so we cannot say the renal involvement. We have to use a specific term. What's that?
Renal artery. Enough.
Yes, excellent, excellent. So in your exam case, as you know, practically that's not even possible to give you a real case of renal artery stenosis. Patients are very toxic. But in part 1 case or even part 2 case, if you are having any question regarding the Takayasu arteritis, of course, there should be some data or some info regarding the renal artery stenosis. Okay. So might be your answer is renal artery stenosis, the given data was regarding the Takayasu arteritis or something like that. They are giving you data regarding the renal artery stenosis. You have to make a diagnosis of the Takayasu arteritis. So this is happening like this way. Okay. So don't worry, we'll get to know it one by one. So as you know, or you can see, the patient is having Takayasu arteritis. So now if you think my patient is having Takayasu arteritis. So now what they're saying that what is the bedside clinical examination we will look for right now? They're saying renal artery stenosis, the patient is having renal artery stenosis, it's already they have revealed the data. Okay, so you shouldn't examine over there. So of course there might be some plus minus bruit. Okay, and they're saying this is a case of Takayasu arteritis again. Okay, or giving you the data regarding the Takayasu arteritis. There's pulseless activity on one hand, unequal BP on one hand. Now at this moment, even they're saying on precordium examination, you have found an early diastolic murmur. So what is the next clinical sign you'll look for, or clinical examination you're going to see, or you're going to perform? Can you tell me? What's that? And believe me, you will be asked in this way even in MRCP cases. Believe me, you will be asked in this way in MRCP cases. The same thing, the same way. What's that? What's that? Anyone? So anyone? So how you can? So what are you going to see when the patient is having something like Takayasu arteritis, and all the info what I've discussed, those have been excluded or have been revealed. Now, what's the next thing? The next thing you need to look for, that is the carotid bruit. Okay, so I want to auscultate the neck. That's the main thing. Okay, so you'll be asked in this way, and you'll have to answer in this way. So so this was all about the Takayasu arteritis. So once the diagnosis is confirmed, what do you need to give? You need to prescribe steroid to the patient. Okay, because it will be a life-saving medication for the patient. Now we're starting with the HOCM. Very important, very hot topic for MRCP part 1, part 2, not in paces, because you know it's very rare. No, I'm not saying very rare, or rather it's totally impossible to get any real case of HOCM in MRCP paces. Okay. So what does it actually mean? This is hypertrophic obstructive cardiomyopathy. Okay. So hypertrophic cardiomyopathy. I'm not saying hypertrophic cardiomyopathy, rather I'm saying hypertrophic obstructive cardiomyopathy. Why I'm saying obstructive? Because there will be some obstruction, and so we will expect some sort of signs of obstruction in case of HOCM. So what's that? This is actually an autosomal dominant disorder. So HOCM is an autosomal dominant disorder. That's very important thing. And I'm saying this is autosomal dominant disorder. So what is the defect? The defect is here, in the contractile proteins here. And what's that? That is the encoding beta myosin heavy chain or the myosin binding protein. And also remember there are a lot of protein other than these proteins. Okay, but the common thing is that the beta myosin heavy chain protein or the myosin binding protein, we call it the MBP, the myosin binding protein. So if you think there's some defect regarding any mutation problem in the gene that encodes the beta myosin heavy chain, the person is high likely to develop the HOCM. And it's not that much rare even in 1 in 500 cases, the prevalence rate here you can see that the 1 in 500. And of course they're saying Over there in UK or over there in Europe, the most common cause regarding the sudden cardiac death, yeah, is the HOCM. I mean hyperobstructive cardiomyopathy, hypertrophic obstructive cardiomyopathy. So what is the feature? Sometimes the patient might be asymptomatic, but regarding the MRCP exam, the patient shouldn't be asymptomatic. Rather, the patient should have problem like short of breath on exertion and racing and pacing of heart. The way I'm saying, also you will be given data regarding this way. So the patient will be having short of breath. The patient will be having racing and pacing of the heart. But always remember, if there is no data regarding pre-syncope, regarding any data regarding the pre-syncope or syncope, that the case shouldn't be a case of HOCM. Okay, always remember, without having any attack of syncope or pre-syncope, okay, you shouldn't make the diagnosis of the HOCM. Again, I'm saying, just by looking at the syncope, pre-syncope, please don't take the answer of the HOCM. Of course, try to rule out the most common thing, that is the vasovagal. Okay, there's the vasovagal. Try to rule it out. And they're saying that this is one of the most common causes of the sudden cardiac death. Why they're having sudden cardiac death? Due to high chance of VT, ventricular tachycardia, ventricular arrhythmia. Or even the patient might have also features of heart failure. Reason the patient might develop problem like short of breath on exertion. So what will be the pulse activity? If you're going to see the pulse in the hands, the patient will have a jerky pulse. That's very, very important. Patient will have a jerky pulse. Okay, so patient might have some jerky pulse and with a large ear, forget about this, and double apex beat. Okay, so the jerky pulse or we always say double click pulse or double systolic pulse or double beating pulse. Okay, so they are saying the jerky pulse or pulses experience as well. So double apex beat. And what's next? Here in this case, the patient who is having hypertrophic obstructive, as I'm saying, outflow obstruction. Reason why the patient is developing a murmur like aortic stenosis. And what's that? The ejection systolic murmur. And how will you evaluate? Well, this is a case of aortic stenosis, not a case of HOCM. This is a case of HOCM, not a case of aortic stenosis. The first thing what actually can guide you, that is the age of the patient. Okay, so if you think the patient is younger, of course the patient should be a case of the HOCM. Again, I'm saying there, as you know, that over there in UK, lot of cases are over there. The patient is having murmur of the aortic stenosis, I mean murmur of the ejection systolic murmur, and at the end of the day, the patient is diagnosed as a case of the aortic stenosis, not a case of HOCM. Why? Might be the patient is having a bicuspid aortic valve. Reason why in younger onset the patient has developed murmur like ejection systolic murmur. So age isn't a definitive thing which can actually save you in exam scenario, but actually it will guide you. It might be a case of HOCM. Again, I'm saying if this is a case of the bicuspid aortic valve, of course aortic stenosis might be another possibility. But how you can differentiate in between this? Just by doing this Valsalva maneuver. This is the most important thing, and you will be asked this. Remember, this is a must question for you guys. So this is the Valsalva maneuver. So whenever you're checking the Valsalva maneuver, the murmur increases with the Valsalva maneuver. As we know, in Valsalva maneuver, of course, the murmur should decrease. Okay, the length and the intensity of the murmur should decrease. And what's that? If the patient is on a standing position, the murmur, the intensity, the sound, okay, and even the nature, the murmur would decrease. But here in this case of like the hyperobstructive cardiomyopathy, when the patient is standing, when the patient is on a standing position, the murmur is more loud. Okay, so we are saying the reversal of the Valsalva. Okay, and it decreases on squatting position. As we know, on squatting position, sometimes the murmur are very louder or very prominent. Reason sometimes we are leaning forward the patient, particularly there in case of aortic regurgitation. Okay. Squatting position for the decrease in pressure, so murmur sound কমে যায়. Yeah, এখানে murmur জন্য কমে যায়. It decreases the murmur over here. So another another guide for you guys, that how you can make the diagnosis of the hypertrophic obstructive cardiomyopathy. There might be some features of the cerebellar syndrome with the patient, right? There might be some features of the cerebellar syndrome. So now you might fall in danger. Why they're giving some problems like the cerebellar syndrome? That might be one thing. And the other thing that is also possible, what's that? The patient might have absent ankle jerk with extensor plantar. Okay, absent ankle jerk with extensor plantar. Everybody please note it down. So the patient might be having absent ankle jerk with extensor plantar, or even the patient might be having problems like cerebellar syndrome. Why the patient is having this and this? Because this is due to the Friedreich's ataxia. Okay, this is due to the Friedreich's ataxia. Well, this is a neurological issue when the patient should have some features like this scoliosis, but not every time you will be given each and every data. Okay, so sometimes from the cerebellar syndrome, you have to, you have to realize that they are giving some data regarding Friedreich's ataxia, and it's common. They're saying that in HOCM, Friedreich's ataxia association with the Friedreich's ataxia is very common. Another thing, what you need to know, that the patient might be having a pre-existing palpitation. Pre-existing palpitation. Why the patient is having a pre-existing palpitation? Reason, the number one reason why the patient is having pre-existing, that is the WPW syndrome. Reason why the patient had only palpitation, nothing else. Okay, in WPW syndrome, palpitation is very common.
Then in the ECG, we are going to find delta.
Yes. Then what we're going to say regarding this association, we'll look for the delta wave there in ECG. Okay, so to see whether there is actually there are some association with the WPW syndrome with this HOCM or not. Of course, there will be some other features of HOCM in the ECG, of course, but of course you have to rule out the delta wave as well. So regarding the MRCP part 1 and part 2 exam, whenever you will be given a case of HOCM, suppose you have given a ECG, you have given an ECG regarding the HOCM, of course you have to look for the delta wave as well, because WPW is associated with the HOCM very strongly over there in UK. So what about the echo findings? In echo findings, now you'll be confused. Why? They're saying here in this case of HOCM, the patient might be having another leaking valve that is called the mitral regurgitation. Okay, mitral regurgitation. Already the patient is having a murmur, which is ejection systolic murmur. That murmur looks like very similar to the aortic stenosis. Now they are saying that the patient is might have also MR. But characteristically, here in this case of HOCM, this sort of MR doesn't produce that typical pansystolic murmur. Okay, so what are the echo findings? We are seeing in the Mr. Sam Ash. What is that, Sam? Sam does mean the systolic anterior motion of the anterior mitral valve leaflet. So systolic anterior motion of the anterior mitral valve leaflet. And what is the Ash? Ash does mean asymmetric hypertrophy. Asymmetric hypertrophy, and believe me, this is the most important thing. This is asymmetric hypertrophy. I will give you the data that what sort of questions they will try to give you regarding this from this information. Don't worry. So in ECG, there will be some features of the HOCM. What's that? There will be left ventricular hypertrophy. Okay, that's very common. There will be some progressive tube inversion. Okay, maybe due to the high cardiac demand. Now there is progressive tube inversion, and there might be presence of deep Q waves once again. Okay, so and atrial fibrillation might be seen, but in exam cases, what I have seen, they are not going to give you atrial fibrillation over there. If the patient is having racing and pacing, I mean the palpitation, that's not due to the atrial fibrillation. That might be due to the WPW issue, or even the HOCM might produce palpitation, but not the atrial fibrillation. Okay, but of course you need to know this. So what is the prognostic factor? Yeah, what I'm saying, if you're not having any sort of collapse at all, or the fainting attack, so that shouldn't be a case of HOCM in the examination scenario. Practically it's possible, but not in the examination scenario. Again, if you're having any data regarding the pre-syncope or syncope, that's something dangerous for the patient, because it's one of the poor prognostic factors. Okay, so having history of syncope or history of pre-syncope, it does mean that the patient is having poor prognostic factors. That's the number one thing. And the other thing is that it will be written in an exam. The patient, the father of the patient or the brother of the patient also had history of sudden cardiac death. It does mean again the patient is having a poor prognostic. Yes, yes. So having family history positive, it does mean it's something bad. And again, young age at presentation. And whenever, as you know, that in every sort of palpitation over there in UK, they try to first rule out the anxiety issue, then the food issue, caffeine, tea, huh? Sometimes even some sort of chocolates, they produce palpitation. So,
relation with hypertension.
mhm.
Is there a relationship between HCM prognostic factor and hypertension?
No, no, not hypertension. Rather, the blood pressure will drop. The blood pressure will drop. So, well, I'll talk about that. So, if you do think the patient is having any sort of racing, pacing of the heart, as you know that we try to do the 24 ECG monitoring. We call it the Holter monitoring. So, if you are getting any data regarding this non-sustained VT on 24 to 48-hour Holter monitoring, I mean any sort of non-sustained VT, it does mean the patient is having prognostic factor, and the abnormal blood pressure changes on the exercise. This is the most important line for MRCP part on, because this is the most common question from the HCM, what I have seen. So abnormal blood pressure changes on exercise. Always I say that please keep this statement top of the list. Okay. So abnormal blood pressure changes on exercise is the most important data from the HCM prognostic factor. So of course you need to know. And the echo findings, as we have said, the increased septal thickness is also associated with the prognosis. Now, how we are going to manage the case? Yeah, there are some medication you need to prescribe. There are some medications, of course, you shouldn't or you must not prescribe. So what are those? The management is simply the A, B, C, D, E. It does mean the amiodarone, particularly if the patient is having beta blockers or the verapamil. C for the cardioverter defibrillator. D for the dual chamber pacemaker. E for the endocarditis prophylaxis. As you all know that in any sort of valvular heart disease over there in UK, they try to prescribe the endocarditis prophylaxis. They always try to ensure that the patient should have be taking any sort of endocarditis prophylaxis. And so this is the ABCDE rule. And drugs to avoid, we call it NAI, N-A-I. So NAI in HCM, okay? NAI in HCM. Yeah, what's that? The nitrate, AC inhibitors, and the ionotropes. So particularly, you'll see the patient is having AC inhibitors over there in exam. Okay, there is a real case what I have seen. The patient is taking AC inhibitor. So what is the next step? Stop the AC inhibitor. That's the answer. The simple answer. So before picking the AC inhibitor, of course, you have to rule out this is the case of HCM or not. Again, the patient is in shock. Can you go with anatropes? No. Okay, so this is another question. Okay, you cannot go with anatropes. Any other thing you have to consider. Okay, any other thing you need to consider, but other than having this or giving this anatropes. So what is the dilated cardiomyopathy? Please don't confuse or don't be confused with dilated cardiomyopathy and restrictive cardiomyopathy. Questions from dilated cardiomyopathy, I mean the DCM and the RCM, restrictive cardiomyopathy, very common in MRCP exam. So now I am giving you data that how you can make the diagnosis. If you think that you are going to make a diagnosis of the DCM, I mean dilated cardiomyopathy, for the examination purpose, the patient should be having systolic dysfunction, minimum. Diastolic plus minus, but the patient should be having systolic dysfunctions. Then we can call it, yeah, this is cardiomyopathy. Okay, so there should be some systolic dysfunction, and then all four chambers affected, but LV more so than the RV. This is a very common thing, so nothing to worry about. And the other thing that's also important, that the patient might have some features like that, arrhythmia, emboli, or the murmur like EMA. And whenever you're going to make the diagnosis of the dilated cardiomyopathy, you have to go through the history in details, like if the patient is already a known case of ISD or not. If the patient is already a known case of ISD, then DCM is never your diagnosis. Okay, DCM is never your diagnosis because DCM is not possible after ISD. If this is so, then you can call it the ICM, I mean ischemic cardiomyopathy, not the DCM. Okay, so always try to rule it out at first, the ischemic heart disease, whether the patient is having ischemic heart disease or not. Always try to rule it out whether the patient is having any sort of murmur or not. If the patient is also having murmur, so that does mean the valves are involved. Okay, so then it's not a case of DCM, it's valvular issue. Where the heart is failing, maybe a valvular issue. And of course the patient shouldn't have any kind of congenital heart disease. So the main three things what you need to exclude before making a diagnosis of the DCM, first of all, ISD, that is most common in the exam. then valvular issue, and after that the congenital. That's actually not common. Okay. So what are the reasons why the patient is having dilated cardiomyopathy? If you are asking me in general, if you are asking me, doctor, what do you think that a patient might develop dilated cardiomyopathy? So then I must say malnutrition. No, why? Why? Because due to the thiamine deficiency. Okay, this is due to the thiamine deficiency, and particularly reason why over there in UK, the patients who are taking alcohol, they're high likely to as you know, their thiamine level is very lower than the normal. Reason why they're developing this sort of beriberi that is causing the dilated cardiomyopathy. So alcohol might be involved with this dilated cardiomyopathy for the exam purpose. And how will you exclude this? Whenever you are giving thiamine, the patient gets some sort of improvement. Okay, so if the patient is getting improvement with thiamine, it does mean that it's a case of the DCM due to the alcoholism or the thiamine deficiency due to malnutrition or any other causes. Here in Bangladesh, what is the most common cause of DCM? Postpartum, or even in Asia, yeah, postpartum. DCM is most common in the young girls in postpartum period. Yeah. Due to malnutrition overall, even I'm talking about the worldwide, okay, but here in Bangladesh, the most common cause of DCM is postpartum issue. Okay, postpartum issue. And the other thing, the patient come up with the features of the DCM, but not in exam scenario. That is the hypertension. Hypertension shouldn't be your exam. We have never seen. So the first two things you have to rule out, and the highly important, that is the alcohol or thiamine deficiency, again the postpartum issue. Yeah, there are some other reasons, and that is also very, very important. Was that if I'm here to take number one, then the number one would be hemochromatosis. Okay, hereditary hemochromatosis, particularly the hereditary hemochromatosis. Hereditary hemochromatosis is associated with the DCM. So you'll see what you will see. There is a common question in the MRCP pattern. The patient has some liver issues, has some jaundice, has some joint pain, and the patient has some short of breath. Okay, short of breath. And in echo, the chambers are dilated. What's the diagnosis? This is the diagnosis of the hemochromatosis. Yeah. So how will you be so confident? There will be another data that will give you 100% confidence. What's that? The patient is somehow infertile. Okay, the patient is somehow infertile. So in hereditary hemochromatosis, always don't actually always look for only the rheumatological issue. I mean the joint pain. No. Okay, you have to look for the liver, you have to look for the joint, you have to look for the heart, then you have to look for the sexual issues. Okay, so this is a must thing there in MRCP exam. The other thing what you need to regarding this dilated cardiomyopathy, after this hereditary hemochromatosis, hemochromatosis, there is the hyperthyroidism. Again, a very important talk. Hyperthyroidism that might be involved with the DCM or the dilated cardiomyopathy. Okay, dilated cardiomyopathy. Okay, that's fine. That's another important question. Okay, and the other reason, that is the drug reason. What is that? The doxorubicin. Okay, doxorubicin. We say that D for doxorubicin and D for dilated cardiomyopathy. That's very, very common in exam scenario. And then the other thing that's also very common, like the Coxsackie virus or the parasitic infection or the diphtheria or the Duchenne muscular dystrophy or any other muscular dystrophy that might be associated with the DCM. Okay, so that is also very, very important for all of us. Now, what about the restrictive cardiomyopathy? Yeah, restrictive cardiomyopathy itself, it has similar features like the constrictive pericarditis. Very similar features like constrictive pericarditis, but a simple investigation which can distinguish between this RCM and the CP, I mean the constrictive pericarditis, that is the chest X-ray. Chest X-ray. Usually in exam cases, not in the practical. Again, I'm saying in the exam scenario, if this is the case of the constrictive pericarditis, there should be a pericardial rim or pericardial calcification. Okay, in exam, only in exam purpose, not in the practical purpose. So in constrictive pericarditis, there should be a rim of calcification, pericardial calcification or rim of the pericardial calcification. There should be something like that. But in restrictive cardiomyopathy, you will expect nothing like this. Okay. So in restrictive cardiomyopathy, there should be something different that don't match with the features of the constrictive pericarditis. So how will you evaluate? Okay. So now they're saying the features that suggest the RCM rather than the CP. What's that? The prominent apical pulse. This is very important. The prominent apical pulse. So in case of, as we know, in case of constrictive pericarditis, the apical pulse is not that much prominent. Okay, we cannot appreciate the pulse in case of constrictive pericarditis, even in cardiac tamponade. Even in cardiac tamponade, we cannot appreciate the apical pulse, okay, or apical beat. And what's the next? Absence of the pericardial calcification on the chest X-ray that I have said. Okay, so there shouldn't be any kind of pericardial calcification or any pericardial rim. Okay, and what's the third thing? That in RCM, even the patient might have enlarged heart shadow. Okay, okay, in RCM, even the heart shadow might be enlarged, or the heart that might be enlarged. But in constrictive pericarditis, no, the heart of course should be that should look like a smaller one. What are the ECG findings in case of RCM? In ECG findings, in RCM, there might be some features like the bundle branch block or the QFs. That not that much specific, so you won't get any other significant data from this. So what is the number one reason why the patient is having RCM? Any chronic disease. Okay, any chronic disease, particularly rheumatoid arthritis. Okay, particularly rheumatoid arthritis, any chronic disease. Why? Chronic disease has led the patient to have features like restrictive cardiomyopathy due to abnormal protein deposition over there in the heart. What's that? Amyloidosis. Right. So, in amyloidosis, there should be a chronic disease. This is the reason why the patient has developed amyloidosis. Okay, so particularly the disease, they usually try to give us, that is the RA. There are a lot of diseases other as well, but somehow they try to give us the diagnosis of disease of the RA. Okay, so RA, number one, that amyloidosis you need to look for. So now how you can be so sure or 100% confident? Yeah, they might be, they're talking about the amyloidosis. The patient might develop nocturnal hypoxemia, or the patient might develop, what's that? Obstructive sleep apnea. Why? Why the patient is having obstructive sleep apnea? We are suspecting this. In case of regarding the amyloidosis, we are now discussing the amyloidosis. So now you're searching for the other data. Yeah, I need to pick the diagnosis of the amyloidosis. Now you have to make it sure reason why you're searching for the other data. So now you have found they have given another data, that is the patient is having obstructive sleep apnea. So is there an association between the amyloidosis and obstructive sleep apnea? Might be there's some good association. What's that? The patient might have some enlarged tongue. Enlarged tongue. As you know, in amyloidosis, there might be some macroglossia. Why the patient is having obstructive sleep apnea. Okay, so now somehow it's not present there. Somehow it's not present there. Now you're searching for the other data. The patient is having the patient is having carpal tunnel syndrome, or the hand pain that is due to the carpal tunnel syndrome. Again, due to the amyloid deposition in the carpal tunnel. This is the same thing. What's the third thing? Suppose this is also absent. So now we are searching for the third one. And what's that? The patient has developed, somehow the patient has developed anasarca, or the patient has some facial swelling, or the patient has some leg edema. What's the reason behind this? And the patient in known case of amyloidosis. Why the patient is having this and this? Always remember, in exam setting, if you are getting anasarca, and in exam setting, particularly in exam setting, if you are getting any case of anasarca, unless otherwise proved, this is a case of nephrotic syndrome. Unless otherwise proved, this is the case of nephrotic syndrome. If the patient is having anasarca, or particularly the facial swelling. So then you have to rule it out. Yeah, might be a case of nephrotic syndrome due to the amyloidosis. Okay, case of amyloidosis. Okay, so that's the thing. That is how you need to evaluate all the things together. So RA, and what is that? Another disease that is also very common along with this nephrotic syndrome, that is the multiple myeloma. Multiple myeloma. Though we don't usually right now at this moment we don't say the multiple myelomas. Some authors they prefer the word of the plasma cell myeloma. Plasma cell myeloma nowadays. So don't worry about that. Okay, so that is the most common cause in UK. They are saying even hemochromatosis might cause DCM and RCM both together. Sometimes with sarcoidosis, plasma as the Loeffler syndrome, and the other thing that is the scleroderma. So now we are going to exclude each and every one. So now pick this one, the scleroderma.
So excuse me.
If the patient
Sir,
is having
Excuse
scleroderma,
me.
sorry,
Excuse me.
yes, sir.
Loveless syndrome and restless syndrome, is there any relationship?
Sorry,
Restless
sir.
syndrome, restless syndrome and Loveless syndrome.
No, no,
Is
sir.
there any?
No, not like that. Loeffler is something associated with the sarcoidosis itself.
Fine.
Okay.
Thank you.
So sarcoidosis, that is why we are going to discuss about this. So in scleroderma, what are the features over there? So now you're going to make the diagnosis of the RCM. And what you can now appreciate only that is the patient is having dysphagia. The patient is having dysphagia. Okay. So that might be a case of simply scleroderma that is also affecting with the heart, and the patient is getting, or the patient is has developed RCM or the restrictive cardiomyopathy. So scleroderma might be one of them. Huh? Okay. And scleroderma, there are other features as well. The patient might have some Raynaud's issue. Yeah. The patient might have some calcinosis in the hands. Okay. So there might be some calcinosis, there might be some Raynaud's. There might be some dysphagia issue due to the esophageal dysmotility. There might be some skin tightening in the hands. We call it the sclerodactyly. And the simple and the most rare thing that would confuse you very easily. That is the patient has some telangiectasia or some rashes in the face. Okay, that is simply the telangiectasia. So this is the association. Okay, this is the association. So in CREST, I mean CREST, CREST, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. Even the patient might develop RCM, restrictive cardiomyopathy. This is the rare presentation. Sarcoidosis is very common in exam, very common in exam scenario. What's that? The patient might be having only simply dry cough, or the patient might come up with the features of the shin lesion. There is a rash, there is palpable or tender on the anterior shin border. Okay, what's the rash? The rash is erythema nodosum. The rash is erythema nodosum, and this is the case of the sarcoidosis. Okay, this is the case of the sarcoidosis, and the patient might have other features like constipation. The patient might have other features like constipation, abdominal pain, or even anxiety. Can you tell me why the patient with sarcoidosis might have this and this? Of course, there should be, the patient should have this and this, particularly in the exam scenario. Not practically, I have seen the patient is having this kind of typical features. But regarding the part 1 and part 2 examination, as they have the freedom or the liberty to give you each and every data, so they will give you this and this. Can you tell me why the patient is having constipation or abdominal pain or some anxiety? Anyone? In sarcoidosis, why the patient is having constipation? In sarcoidosis, why the patient is having abdominal pain? In sarcoidosis, why the patient is having or developing anxiety? What's the reason? This is due to, I know you can do it. This is due to high level of calcium. Okay, so this is due to hypercalcemia. So there will be only features of the hypercalcemia, and of course there will be only features of the hypercalcemia regarding the sarcoidosis, and you have to make the diagnosis. Okay, so even without having any cough history, sometimes you have to make the diagnosis of the sarcoidosis by these and this. Particularly if you think the patient is having features of hypercalcemia, but in exam setting, particularly in exam setting, if you think the patient is having features of the hypercalcemia, features of hypercalcemia, like these and what I have discussed. Again, there are another feature might be present, that is the acute pancreatitis. Okay, so if you think the patient is having these and these due to hypercalcemia, the first thing you need to exclude, that is the primary hyperparathyroidism. Okay, that's the commonest thing in MRCP exam. Primary hyperparathyroidism. That's the first thing. The second thing, what is that? There is the vitamin D intoxication. Vitamin D intoxication, and that will be enhanced by taking thiazide diuretics. That will be thiazide diuretics will be contributing to this factor in an exam scenario. There is a common question, and I think we will get this question as well. So vitamin D toxicity with thiazide diuretics. Reason why? Both of them has caused high level of calcium. The third thing, what we need to exclude, that is the carcinoma. Okay, carcinoma might be anything. Carcinoma might be lung carcinoma. Lung carcinoma even cause hypercalcemia. Okay, multiple myeloma might cause hypercalcemia. Okay, so any sort of carcinoma you need to exclude, particularly the lung carcinoma. That's the most common in MRCP exam. The fourth one regarding the hypercalcemia, of course you need to exclude, that is the sarcoidosis. Okay, so if you are getting any data regarding the sarcoidosis, you have to exclude these in this way. Okay, so in sarcoidosis the patient might develop some respiratory cardiomyopathy, and somehow in sarcoidosis the heart involvement like this way, I mean the respiratory cardiomyopathy is very common. Okay, so you cannot underestimate this info in okay. So now another important topic, and that's very important topic, that is the ARVC. There's a second most common cause of death, of sudden cardiac death, due to second most common cause of death due to the sudden cardiac death. What is that? That is the ARVC, I mean the arrhythmogenic right ventricular cardiomyopathy. What it happens here, let me give you the idea. Basically here in this ARVC, the right ventricle, okay, we all have two ventricles, left and right. But particularly here in this ARVC, I mean the arrhythmogenic right ventricular cardiomyopathy, the right ventricle, the myocardium is developed. Yeah, the fat takes the place. Yeah, yeah. Reason why, as you know, the right part of the heart, okay, right part of the heart, they are responsible for the signaling purpose. Okay, like the SA node, AV node. Okay, the right side of the heart, as you know, plays a very important role for signaling purpose. So when there is malfunctioning of the right ventricle, the patient is high likely to develop any sort of arrhythmia that is due to the arrhythmogenic right ventricular cardiomyopathy. And believe me, the appropriate investigation for this is not the echocardiogram, rather this is the MRI of the heart. And this is the question. And this is the question. Okay. So what will be your best investigation for this disease? So everyone usually takes the echocardiogram. No, why echocardiogram? Echocardiogram shouldn't be the answer. This is the MRI. Anyway, the features might develop, features like the palpitation or even some attack of the syncope. Okay, and they are saying this is the second most common cause of death due to the sudden cardiac death after the hypertrophic or the HOCM. And this also some autosomal, it has some autosomal dominant fashion, and it is replaced by the fibrofatty tissue in the right ventricle, as we have said. So the presentation of the palpitation, simply the racing pacing of the heart, simply the collapse or faint attack, or simply the patient is coming up with sudden cardiac death. So what is the ECG features that I have given to you guys in our Telegram, and I appreciate Dr. Anand sir that he has made the diagnosis correctly. And in ECG abnormalities, you will see that from the V1 to V3, there will be some TF inversion. There will be some TF inversion. And as you can see here, there might be some epsilon wave that is found in about 50% of the cases in arrhythmogenic right ventricular hypertrophy. And this epsilon wave, and along with this T inversion from V1 to V3, will confuse you in the exam. In which manner? Just by making it a case of RBBB, right bundle branch block. But no, this is not a case of RBBB, rather this is a case of the ARVC. So please be sure about that. Okay, be sure about that. Okay, this is not the typical M pattern we look for there in RBBB. Yeah? So of course you have to be very careful regarding this thing. So what are the echo findings? Basically, in echo findings, they are very subtle in early stages, but may show enlarged, but the heart is not moving well. So we're calling it the hypokinetic right ventricle with a thin free wall. So what's the investigation? The MRI. MRI is the useful investigation, as you can see here. The MRI is the useful investigation if you want to see the fibrofatty tissue over there. So now, what are the management system here? Well, in ARVC, the medication like the sotalol is the most widely used antiarrhythmic. That is the highly important question in MRC pattern as well. You will be asked this in this way. What's the next management option you have in your hands? So that is the sotalol. And what next? Catheter ablation to prevent ventricular tachycardia. So catheter ablation is another thing. And what next? That is the ICD. So what are the candidates for the ICD? If the patient is already having attack of syncope or pre-syncope, then usually we do consider the ICD. So now, of course, definitely.
fast as possible.
Right.
So there should be issues with their movement, there should be issues with their growth.
Of course. So what will be the features? Particularly, the features should be something like that. The patient was playing football. Are you a very young patient? He was playing football on his school ground. Now the patient came to you with histop collapse. So then try to exclude three things if the patient is coming with these features. Okay, a school boy has got collapsed when he was trying to play cricket or football in school premises. So the first thing is ASOCM. Second thing is ARVC. The third thing is Brugada syndrome. Okay, so these three things is very common regarding the MRCP exam, and as you have said it, the features are something like this way. I mean, on exertion, features will develop on exertion, on exertion. Okay, so the exertional issues will be given to you. Anyway, another disease that is common in MRC part 1, but I have never seen question coming from this nexus disease in MRC part 2, not even in PACES, that is the nexus disease. This is the autosomal recessive variant of the ARVC, and here the patient will have a triad. Of course, the patient will be having ARVC and another the other two things, that is the keratosis in the palmoplantar area and the hair will be woolly. Okay, so nexus disease, these and these and these. Okay, just know these things together. Now, what of the Brugada syndrome? Another very important question, but the prevalence is very high. That is the 1:5,000 to 10,000. So Brugada, why need to know about the Brugada? Because this is the common in Asia. Okay. So Brugada is onset of channelopathy. Okay, onset of channelopathy. So what's that? In around 20 to 40% of the cases, that's caused by the mutation in the SCN5A. N means natrium, I mean sodium. So SCN5A gene, which encodes the myocardial sodium ion channel protein. Okay, so that's very common, and you will be given this question and you have to answer this. This is due to SCN5A gene mutation. So how will you make the diagnosis of the Brugada syndrome? Very important question for emergency part 1, even part 2. So in ECG, you can see the patient is having convex ST segment elevation that is more than 2 millimeter in greater than 1 of V1 to V3 followed by the negative T wave. Okay. So in Brugada syndrome, always listen to me very careful, doctor. In Brugada syndrome, the patient must have a negative T wave. Okay. If that's not negative, so that's something else, not a Brugada case in exam. Okay. So of course there might be some convex ST segment elevation along with the negative T wave inversion. Okay, negative T wave, I mean T wave inversion. Suppose the patient is having ST segment, upright ST segment in V1. Suppose the patient is upright ST segment in V1, and the T is also upright. Okay, so there's no, yeah, so that might be a different thing. Yes, channelopathy.
Opposite direction.
Right.
There will be negative.
Right. So what's that? Might be a case of posterior MI. Okay, that might be a case of posterior MI. So before excluding or before taking a diagnosis of the Brugada syndrome, try to exclude whether the patient is having also the posterior MI or inferior MI with posterior extension. Okay, so be very careful. So I know the age will guide you, but not every time. Not every time they will give you the age. Okay, sometimes they will say a boy came to you with this and this. Okay, or a male patient came to you with this and this, huh? Or a farmer or cricketer has came to you with this and this. So this is how you have to make the diagnosis. Another thing, in Brugada syndrome, the patient might have partial right bundle branch block. In exam, of course, the patient should have right bundle branch block. I mean the M pattern in V1. Don't worry. The patient will be having M pattern in V1, and changes may be more apparent following the flecainide. It's not that common. So now we can see here. Oh, by the way, here they're saying the changes may be more apparent following flecainide. By the way, do you know, can we prescribe flecainide in a structural heart disease? Simply no. The answer is no. Flecainide. Yes. You no. So you cannot prescribe the flecainide in structural heart disease. Okay. So always remember this thing as well. Now ECG showing the Brugada pattern most marked in the V1, which has an incomplete RBB, downsloping ST segment, and the inverted TF. And the most common ECG that will come to your exam, also you'll find it in the Google as well. The most common ECG from the Brugada syndrome that will come to your exam in MRCP part 2. I have already given it to you in the Telegram group. Okay. So how will you manage the case? Imbrugata is managed by the ICD, I mean the implantable cardioverter with the defibrillator. And what about the myocarditis? That's again very important in MRC part 1 exam, not that much important in MRC part 2, and not even important for the MRC paces. Anyway, so regarding the myocarditis, the most important thing is definitely the Coxsackie. Coxsackie is the most common thing regarding the myocarditis. Second most common thing regarding the myocarditis is Chagas disease. Okay, Chagas disease. Okay, so the second commonest thing is the Chagas disease, myocarditis. The third thing that is also very common regarding the myocarditis, that is the autoimmune. Okay, so autoimmune panel, of course, you have to look for. So anyway, as I've said, the Chagas disease. Oh, another one, that is the Lyme disease. I mean the Chagas and Lyme both together. Okay, Chagas and Lyme disease. Okay, Chagas and Lyme disease. They'll come up. Both of them are coming with the same features in maximum cases: Chagas disease and the Lyme disease. So now let me talk about the Chagas disease. How will you be sure that this is the case of the Chagas disease? Particularly there in Chagas disease, the patient might have also features of dysphagia. Okay, the patient often might develop even a chagoma, but in case of Chagas disease, the patient might have dysphagia. So if you do think the patient is having chest pain with features of the dysphagia, the patient has a history of traveling, so you need to explore the Chagas disease first. Another thing that is also common, that is I've said the Coxsackie and the other things are 50-50. What about the presentation? Usually the young patient with the acute history, and the patient will be having chest pain and short of breath. That's the most common thing. Okay, so chest pain and short of breath, and the patient should be a young patient. As now let me give you the idea. If the patient is having acute chest pain, okay, acute chest pain, and the patient is very young, if you think the patient is very young, then acute coronary syndrome shouldn't be the case actually. In generally, yeah, actually it's not common and it's not even relevant. Though there are so many cases, but we are dealing with the normal thing. So in young cases, that shouldn't be a case of the acute coronary syndrome. So what next? Then of course you need to exclude the. So in which congenital issues the patient might develop chest pain? Any other thing? No. So if the patient is having acute chest pain, as I'm saying the acute chest pain, so for that reason, the number one thing in young adult, whether the patient is having any substance abuse or not, particularly cocaine. Regarding the MRCP exam, if you are dealing with the FCPS exam, you can never ever say cocaine at first. Okay, you're going to fail. So at first, you need to exclude the cocaine. So how you will be sure the patient has taken cocaine? They will give you the data regarding this. The patient has the night before, the patient has attended a party. Okay, in this way. Okay, or the patient went to a trip. Okay, and last night she came back or he came back in this way, or or directly they will say the patient has taken cocaine or amphetamine, something like that. Another thing by which you can exclude your differentials, that is the myocarditis. That's very common. So if you think the patient is also having fever, of course the viral thing, I mean the Coxsackie virus, even the COVID, you have to exclude in case of myocarditis.
COVID and myocarditis.
COVID even can cause myocarditis. COVID virus even can cause myocarditis. Okay, even can cause false level of high level of tropi. So myocarditis you need to exclude. Another thing that I've said that's very important, if you do think that they are giving you some data regarding the trip, then you can consider Chagas disease, Lyme disease, or if you do think the patient has typical features of seroconversion, then of course you need to consider HIV as well. Okay, another thing, the patient is taking chemo. So of course that might be another reasons why the patient has developed. Sorry, we are dealing myocarditis. Yeah. So these are the things. So then doxorubicin, of course you need to exclude. Now, myocarditis, reasons behind the myocarditis, you have excluded this question. What are the next? Why the patient is having myocarditis? Like, I mean acute chest pain. Patient is having acute chest pain. Patient is having palpitation right now. Patient is a female patient. She's a female patient. So then you need to consider pulmonary embolism. Okay, so pulmonary embolism. So female patient coming up with acute chest pain with palpitation, unless otherwise proved, you must exclude pulmonary embolism at first. So how you'll be sure this is a case of pulmonary embolism? In ECG, they will say the patient is having sinus tachycardia. Please don't look for the typical S1, Q3, T3 pattern, because they will never ever give you this idea or never ever give you this note. Okay, so there will be simply sinus tachycardia. And of course, remember, sinus tachycardia is, if the patient is having sinus tachycardia and having chest pain, they're high likely to having, the patient might have pulmonary embolism. If you need to be overconfident, then might be there some other data, like the patient is already known case of the SLE, might be associated with the antiphospholipid antibody syndrome, might be another issue. Or the patient is already having a previous attack of the DVT, or the patient has history of recent surgery, history of prolonged immobilization, history of taking OCP for a long time. So they will give you data regarding the pulmonary embolism. Now, the patient is a male patient. The patient is a male patient. Patient came to you with the severe acute chest pain. Acute severe chest pain with short of breath. Patient is a male patient and no other features of pulmonary embolism. No sinus tachycardia, nothing. Only tachypnea. Yeah. And patient is having acute short of breath and chest pain, severe chest pain. The only one thing that the patient has some vision problem. Okay. The patient, only one thing that's given to you, the patient has only vision problem. What might be the cause? Why and what's your diagnosis regarding this info? That might be a case of pneumothorax. That might be a case of pneumothorax. Vision problem with pneumothorax. What's the correlation? Might be a case of Marfan syndrome. Might be not. That should be a case. Must be a case of Marfan syndrome in exam setting. Okay. So in Marfan syndrome, the patient is high likely to develop pneumothorax. So if you are given any question regarding the pneumothorax, three things you need to exclude. Three things. At first, the commonest thing, even in every country, that is the pneumothorax due to any secondary issues like COPD. So of course, might be a pre-existing emphysematous bulla. Now it has got worse, and now the patient has developed pneumothorax. So you have to rule out the COPD. So the age and the smoking history will guide you. The number two thing that is very important, that is the pneumonia. What pneumonia? What pneumonia can come up with the features of pneumothorax? Anyone? Try. What pneumonia can come up with the features of pneumothorax, even at first presentation? That is the pneumocystis jirovecii. Okay, in HIV patient. So if you think they're saying the patient is already known case of HIV, so now you know the patient is high likely to develop pneumothorax. And reason why we always try to give cotrimoxazole when we can see the CD4 count is now is very poor or very low. Okay, so that we can avoid or we can ultimately prevent the attack of pneumocystis jirovecii infection or pneumocystis jirovecii induced pneumonia. Subsequently, we can reduce the chance of having pneumothorax. The third thing, what you need to exclude, there is a Marfan syndrome. So Marfan syndrome. So these three things is very common in MRCP exam. Number one, I would say COPD. Number two, pneumocystis jirovecii, I mean HIV pneumonia presentation with pneumothorax. The third thing, that is Marfan syndrome. Okay, Marfan syndrome. So be very careful regarding this way. So in acute case, and the other thing, then you can consider the other, like the pleurisy, okay, like the serositis. I mean all the others you can exclude. Now regarding the heart failure, don't rely too much on this info because this is wrong here. Guidelines, as you know, that it has been changed. Now we are using the Fantastic Four to treat the case of heart failure patients. And what's that? We're not using the ACE inhibitors. Currently, it's saying they are saying to use the ARNI, angiotensin inhibitor with neprilysin inhibitor. Okay, ARNI, ARNI. So ACE inhibitor, that's fine. So ARNI. Somehow, even RCP is not following the new data. They are giving the questions from this one. Reason why we didn't have actually changed these informations. Okay.
So they can give questions
No.
from this, or they can give from ARR.
Suppose if you think that if you can see ARNI is there, So of course, Arnie would be your answer. Okay, Arnie would be your answer. But so far, they have never ever given the Arnie in the examination scenario. Okay, never ever. So AC inhibitor, of course, you need to prescribe the patient with the AC inhibitor, and then you need to give the MRA, mineralocorticoid receptor antagonist, that is the spironolactone. Then you need to give the beta blocker. Can we give every type of beta blocker like the metoprolol? Can we prescribe metoprolol in heart failure? So metoprolol, atenolol. We have seen so many doctors giving atenolol. So yes, so you cannot give every sort of beta blocker to the patient due to heart failure. Only three medication. Only three medication. Okay, three type of beta blocker. What's that? Number one, bisoprolol. Number two, carvedilol. Number three, nebivolol. Okay, only these three. Okay, so again, bisoprolol, carvedilol, nebivolol. So these three, I mean the BCN, always remember these three beta blocker only you can prescribe due to heart failure issues. Okay, due to heart failure issues. Okay, not the angina issues. For the angina issues, we can prescribe atenolol. Okay, for the angina issues, we can even prescribe the metoprolol, but not for the heart failure. Okay, this is how you need to make yourself prepared. Now the fourth drug, that is hydralazine with nitrates. No, we are not using the hydralazine with nitrates. Rather, nowadays we are using the SGL2 inhibitors. Okay, SGL2 inhibitors. Okay, so SGL2 inhibitors. I mean all the empagliflozin or any other gliflozin. Okay, so I mean the SGL2 inhibitors. So these are the fantastic four medication currently we're using. Here you can see the only diuretics here, that is the MRI, I mean the spironolactone, not the Lasix, I mean not the furosemide. Okay, not the furosemide. So yes, we are using the furosemide, I mean the loop diuretics, but they're saying no long-term reduction in the mortality has been demonstrated for the loop diuretics such as furosemide. So again, that's very high likely to come in MRCP exam. So which medication won't be your answer? The furosemide. But practically, the most common medication that we are going with, that is the Lasix, I mean the furosemide. That is the fallacy. Okay, so that is how we have to be very careful regarding this thing. Anyways, you have tried all this fantastic for, but again, you're not getting any improvement. So now what you can go for? Then you can choose the digoxin. Okay, and they're saying the cardiac resynchronization therapy. So this is the you can go for simply the CRT, I mean the cardiac, but not every patient is suitable or the candidate for the CRT. I will talk later that who are the candidates for the CRT. CRT is now very hot topic over there, even in our NICVT. So CRT or digoxin, particularly when you will prescribe the digoxin, if you can see the patient is also having atrial fibrillation with fast heart rate, with heart failure, then digoxin is the drug of choice. Okay, so not every patient will give the digoxin, particularly will reserve this medication for the patient with atrial fibrillation. Okay, so if the patient is having atrial fibrillation, then we'll prescribe digoxin. No atrial fibrillation,
We don't give
no. Usually we don't try to give the digoxin unless otherwise it's very necessary. Nowadays, you can see that we are giving the evapprex or evapbradine to the patient. When we can give evapbradine to the patient, as you know that evapbradine will reduce the heart rate significantly. So if the patient is already having heart failure with heart rate of only 60 or 62 beats per minute, no, you cannot prescribe evapbradine because the patient will develop bradycardia. Okay, even the patient might develop sinus any moment. So if you're going to prescribe evapbradine, of course the patient should have heart rate more than 75. Okay, so this is the parameter, or this is the criteria for giving evapprex or evapbradine. So heart rate should be more than 75, and of course the patient should have features of heart failure. Okay, and that should be evidenced by ejection fraction less than 35%. Okay, so here you can see 30, 75, 35, 75, 35. So these two is high, very, very important. And cardiac failure, I mean heart failure patients, as you know that the heart failure patients are somehow immunocompromised. So we need to give the vaccination program. As you know, in two cases, very commonly two cases, we are going with the vaccination issues. Number one is the splenectomy, post-splenectomy period. we must prescribe vaccination schedule to the patient, and the second one is CCF, okay, cardiac failure. Yeah. If you're going to consider any third thing, that then should be another C, that is the COPD, advanced case of COPD. You need to enroll the patient with the vaccination program. These three. You need to consider the fourth one, then that would be cystic fibrosis. So don't forget these four. These are the candidates. You have to go with these and these. Okay. Okay. So now they're saying that beta blockers. Yes, you can choose the beta blockers. But the options you have in your hand, that is the bisoprolol, carvedilol, and the nebivolol. Okay. So this is the BCN theory. And what are the candidates for the dioxin? They are giving me that. Yeah. Now the heart failure. So heart failure, as we know, that heart failure, we generally follow the classical NYH, I mean the New York Heart Association classification. In class 1, the patient shouldn't have any sort of symptoms. The patient even have no sort of has no sort of even limitation on ordinary exercise. In NYH2, I mean the class 2, the patient should have some mild symptom and slight limitation of the physical activity, and the patient might develop some sort of fatigue, palpitation, or dyspnea. In NYHA class 3, the patient will develop moderate symptoms and marked limitation of the physical activity. That does mean the patient is comfortable at rest but less than the ordinary activity results in symptoms. NYHA class 4, the patient is totally symptomatic even at rest, even at work. So heart failure diagnosis. Now you have to make the diagnosis. Suppose a patient came to you with the features of short of breath. A patient came to you with the fear of severe short of breath. Also, there are some leg edema. Okay. Also, there are some leg edema. Also, there are some basal crepitations. Now you need to consider whether this is a case of heart failure or not. Tell me one investigation, just one investigation that will give you the idea of heart failure or not. Only one investigation, as I've said, only one investigation you can go. You can go with only one investigation. What is the investigation that will exclude? Yeah, the patient is having heart failure or problems other than heart failure. What's that? That is the NT-proBNP, not the echocardiogram. Okay, so never ever take the echo. Is the answer? No. Yes, NT-proBNP. Okay, so NT-proBNP you have to look for. So then, if you think, yeah, then you have to consider the other data. Like the patient has already history of previous MI, I mean the old MI. Then patient is high likely to develop heart failure, edema due to heart failure. Then you can consider echogram in an urgency basis, like cardiogram, echo within 2 weeks. Okay, not the emergency basis. So no previous of the record of the MI. The patient has no previous history of the myocardial infarction. Okay, so then you can consider. Then of course you need to consider this the BNP. And if you think the patient is having high level BNP or simply the raised level BNP, if the patient is having high level BNP, you need to consider the echo within 2 weeks. Or if you are having the raised BNP, you can consider within the 1.5 months. Now let me give you the idea that what does it actually mean, that high level or the raised level. Actually, here in our country, our cardiologists, they also say the same thing. What's that? If you think the lab report of the BNP is more than 2000, okay, more than 2000, it signifies, yeah, the patient is having heart failure, more than 2000. But be assured that NT-proBNP in a normal individual is the level of NT-proBNP is not more than 200 only, not more than 200 only. Though in your notes it's written that 400, but in typically not more than 200. Okay. So if the patient is having NT-proBNP more than 200, in previous time the doctors usually used to think, yeah, this is the case of heart failure. But nowadays the cardiologists they are saying, if the NT-proBNP is more than 2000, this is high likely the patient is having heart failure. But if you think the NT-proBNP is 400 to 2000, so it is a raised level, not the high level. It is a raised level, and the causes behind this raised level, so many causes. Like in CPR, okay, there might be some high level, okay, and there might be some other causes as well. Now we are going to look for what are the causes. Like in case of diuretics, if you use diuretics, the level of the NT-proBNP will fall. The level of the NT-proBNP will fall. So it's not a good idea to run for or to go with the test like the NT-proBNP while the patient has been taking diuretics for a long time. It's not a very good idea. Now again, the reasons why the patient might have some increased BNP levels, like any sort of left ventricular hypertrophy or any ischemia or any tachycardia, right ventricular overload or hypoxemia, or if you do think, sorry, yes, diabetes or the liver cirrhosis, the patient might have the high level of BNP level. You will be given a question from this data, must, and must. So this info or this chart is 5-star important. And the medication, I mean the medication for the heart failure, it will cause low level of the BNP, like the diuretics, SC inhibitor, beta blocker, or the ARB or the alter. I mean all the medication for the Fantastic Four. Now, heart failure and the non-drug management. Yeah, as you know that sometimes we'll consider the CRT, though in CRT patient they actually get the symptomatic relief, not the mortality benefit. Huh? So in CRT, I mean the cardiac resynchronization therapy, the patient only get the symptomatic benefit, not the mortality benefit. So now let me give you the exact data, who are the first candidates for the CRT. If you're going to consider the CRT for the heart failure patient, of course the patient should have heart failure, otherwise we are going to prescribe or going to enroll the patient with the CRT therapy. So if you think the patient is having heart failure, along with in ECG there must be white QRS. This is the number one thing that you will be asked for, the white QRS. So in MRCP part 2 you will be given a ECG, and then you will be asked whether you will consider the CRT or not. If you can see now the patient is having narrow complex, narrow complex tachycardia, narrow complex bradyarrhythmia, whatever it is, the complex are narrow. No, they are not the case for the CRT. In CRT, the patient should have white QRS. Also, if the patient is having biventricular pacing, also you can consider the CRT as well with this biventricular pacing machine device. Or the improved symptoms or reduced hospitalization in near class 3 patients. I mean, after by giving the CRT, the patient should improve or get some symptomatic relief. They are saying. So now, what about the atrial myxoma? Again, a part on question, very common question. Atrial myxoma. I have the 5-star talk. Actually, atrial myxoma come up with the features of pyrexia of unknown origin. Okay, so if you do think you have got a case of the pyrexia of unknown, like here in Bangladesh, if you can see, or over there in India, or over there in Sri Lanka, or over there in Nepal, particularly here in the southeast part of the globe. So if the patient is having pyrexia of unknown origin, the first thing we try to exclude, that is the tuberculosis, isn't it? Pyrexia of unknown origin, we try to exclude the tuberculosis. But over there in MRCP exam, if you think the patient is having any pyrexia of unknown origin, of course there might be any sort of underlying abscess or anything else. But what two things you need to exclude? Number one, that is the myxomatous change. Myxomatous change. I mean the left atrial myxoma. Number one thing. Number two, that is the connective tissue disorder. Again, number three, that is the subacute bacterial endocarditis. These three. Okay. So there in MRCP exam, if you are going to exclude or if you are going to make a diagnosis regarding or from the prompt of the pyrexia of the unknown origin, of course you need to exclude these three at first. Then you can exclude the other common like the lymphoma and TB. The other common.
So in first one country the criteria, in third one country the criteria.
Absolutely. This is how. Okay, we are dealing with a patient. Okay. So atrial myxoma, like suppose a patient like here in BCM as well. Today we have got a patient. The patient has developed left-sided pleural effusion only. Okay. Left-sided pleural effusion, and the patient has severe chest pain. Though the patient has severe chest pain and left-sided pleural effusion, if asking you, and this is the acute onset, if asking you, you need to exclude, if you're going to exclude anything else other than the carcinoma, as the patient has no features of the carcinoma, patient is not elderly one, no typical features of this or history of smoking as well. So here in Bangladesh, we'll exclude the pneumonia at first, parapneumonic effusion, then we'll exclude the TB, tubercular effusion or not, or malignancy. But over there in UK, if the patient develops, I mean, pleural effusion, and the patient has chest pain with pleural effusion, of course, you have to exclude the serositis at first. Yeah, because serositis, the patient should have chest pain. So of course you need to run the ANA and NDDS DNA. and the DSDLA. Okay, so this is how we are practicing actually here in country. So anyway, in atrial myxoma, when it happens, the patient might develop pyrexia of unknown origin. Even the patient develop clubbing, weight loss, and fatigue, all the constitutional symptoms here in this atrial myxoma. And why we're too much worried regarding the atrial myxoma? If this is persisting, or if we are not treating the case of the atrial myxoma, high likely the patient is going to develop stroke due to embolization. Okay, high likely the patient might going to develop some embolization, and the patient might develop as well the atrial fibrillation. So what would be that murmur type? The patient will develop the mid-diastolic plop or mid-diastolic murmur. We call it the tumor plop. Myxoma is one sort of tumor. Myxoma, oma means tumor. Yeah. So what are the echo findings? In echo, you can see the peduncular heterogeneous mass typically attached to the fossa ovalis region of the intervertebral septum. So okay, now we're going to take a break, and after the break, we'll start with the cardiac component. Yeah, and we have a very important hot topic today, that is the hypertension. This is a mass topic. 2 questions from hypertension you need to encounter. So we're taking a break, and after the break, we'll try to discuss on cardiac component and hypertension. Let us begin. So let us begin. So we're starting with the features of cardiac tamponade. Another very hot topic over there in MRCP part 1, part 2, not in PACES, because you shouldn't get any real case of cardiac tamponade over there in PACES. Very unstable case. So how the case of cardiac tamponade will be presented to you in exam scenario? The patient will be having short of breath. Okay, so in cardiac tamponade, the patient will be having short of breath. Also, the patient will be having racing and pacing of heart. I mean tachycardia. The most important thing that you need to know regarding the cardiac tamponade is hypotension. This is the most important thing. Okay, from my side, I'm saying to you. So this is the most important thing. That is the systemic hypotension. Number 1. Now, whenever you're going to auscultate the precordium, you'll see the patient is having muffled heart sound, or the heart sound is not that much audible. Okay, so tara ki bolte pare, what actually they will say, the heart sounds are very silent, not much appreciated, not much audible. So then you have to rule it out. Well, the patient is having the patient is having hypotension and the heart sounds are muffled. So then you have to think, yeah, might be a case of pericardial effusion, or the patient is having cardiac tamponade. Also, the patient will be having pulsus paradoxus. We all know about it in our first class, from our first class. Kussmaul signs, actually Kussmaul signs is not present here, rather Kussmaul signs is present in constrictive pericarditis. So please forget about this one. And ECG, there might be some features like the heart failure, I mean electrical alternance. Okay, so now we'll evaluate in between this, I mean whether this is a case of cardiac tamponade or the constrictive pericarditis, because both are almost same. So in ECG, I am starting with this ECG. Actually, in pericardial tamponade or cardiac tamponade or pericardial effusion, in ECG, the ECG should have lower voltage. Okay, so if you are getting lower voltage ECG, again remember, if you are getting a lower voltage ECG, I mean the the R waves are not that much tall. Okay, all that R waves are shorter. I mean the low voltage ECG. So in exam purpose, if you're getting the low voltage ECG, at first rule out the hypothyroidism. Number two, rule out the cardiac temporal. Please don't think about the obesity. The most common things what you used to know regarding our what session in during what session or what round. Yeah, our mentors or even our teachers used to ask us that what are the features of the low voltage ECG, and if you are not saying the obesity, so they used to become very angry. No, this is not your professor's class. This is MRCP exam. So not the obesity, not the chest deformity. No, please forget about this blah blah. So you need to first thing you need to rule out, that is the cardiac tamponade, and the second one the hypothyroidism. What the hypothyroidism first one, the cardiac tamponade the second one. Okay, if you're getting the low voltage ECG. So anyway, regarding the JVP, in pericardial tamponade, you can see here in pericardial tamponade or the cardiac tamponade, there will be no Y descent. But in constrictive pericarditis, you can see the patient is having X and Y both together. Okay. So in JVP, constrictive pericarditis, both are present. I mean the X and Y, but in JVP, the Y is absent. So we're calling it the Tampax. I mean, in pericardial tamponade, already X is present. Rather, reason why we're calling it the Tampax. Okay. Now, what are the pulsus paradoxus? You all know in pericardial tamponade, there will be more reduction of the systolic during the inspiration time. So this is the pulsus paradoxus. And the Kussmaul signs, it's rare, not actually present. And in constrictive pericarditis, this is present. And as I've said, in constrictive pericarditis, the most phenomenal sign, okay, that is the pericardial calcification rim on the chest X-ray. Okay, so always try to remember this one. Now, what about the pericarditis? Again, a pericarditis is a very hot topic for MRCP part 1 exam, particularly important in MRCP part 2. Particularly why? Because there is a characteristic issue of pericarditis. All you know. Here in case of pericarditis, the patient should be having chest pain that is pleuritic in nature and that is relieved by sitting forward. That is the most important line here. So in pericarditis, the patient will be having acute chest pain that is pleuritic in nature, not the cardiac in nature. Pleuritic in nature. So, but the reason is pericarditis. Remember, the reason is pericarditis, but the chest pain is pleuritic in nature. Is often relieved by sitting forward. This is the most dynamic line here. And other symptoms that might be present, that is a non-productive cough or short of breath or any sort of flu-like symptoms. Another dynamic sentence or dynamic line for you guys, that is the pericardial rub. So in particularly if you are getting pericardial rub, please try to rule out the uremic pericarditis. Okay, if you are getting any pericardial rub, try to rule out the uremic pericarditis. So yes, so uremic pericarditis, the patient who is having uremic pericarditis, how will you get it to know that the patient is having uremic pericarditis? You know, in uremic pericarditis, the patient also should have some features of uremic encephalopathy. Okay, so if you think the patient is having a pericardial rub and on CNS manifestation, the patient is showing features of encephalopathy, okay, and they are saying the ABG report, okay, they have given the ABG report to you and it's saying the patient is having metabolic acidosis. It does mean there is renal failure. Why the patient has developed uremic pericarditis, okay? It does mean patient is a candidate for dialysis. You know, uremic pericarditis is a indication. Yes. Right. For this reason. So uremic pericarditis means if the patient is having pericardial rub. So having pericardial rub due to uremic pericarditis, it does mean the patient needs immediate hemodialysis, HD. Also, the patient might have tachypnea and tachycardia. So what are the results of the pericarditis? Again, the myocarditis and the pericarditis will be caused by Coxsackie. Here, what you need to know, number one reason of the pericarditis, as I've said it, that is the uremia. Number one. If I'm talking regarding the second one, I mean the number two, that is the tuberculosis. Okay. So regarding the pericarditis, the number one should be uremia. That is the most common for regarding the MRCP exam. Number two, not that much common in MRCP exam, but very common for your practical life as well. You will be asked every time in your what session, whenever there will be a case of pericarditis. What are the causes? If you are not seeing regarding the TB, so you're in big danger. Then the other thing you can consider, like the patient has history of MI 1 month back, reason why the patient now has got developed pericarditis. We know we call it the Dressler syndrome. So post MI, post-MI issue, and that is the most common regarding our professor's expectation, but not common in MRCP exam. The other things what you need to know, that is the malignancy and connective tissue disorder. So these are the causes of the pericarditis. So in pericarditis, what are the ECG findings? We all know two type of findings in the ECG where we'll get some elevation, some depression, some elevation, some depression. What is the elevation? That is the ST elevation, and that is the widespread saddle shape ST elevation. And what is the depression? That is the PR depression. And they are saying regarding these two or in between these two, which one is the most specific, okay, and more sensitive? That is the PR depression. That is the more specific and sensitive for PR depression. And this is a common question in MRCP part 1 exam as well. What is the most common finding or the most specific findings in pericarditis? That is the PR depression. Okay, so PR depression, always remember this word. Yeah, PR depression. PR depression. So widespread PR depression, widespread ST elevation. Okay. Now hypertension, as I've said it, that is the hot topic, most important topic regarding the MRCP part 1 exam. So now, suppose you have got a case of hypertension in your exam. So if you are going to get a question regarding hypertension in your exam, so it should be a secondary hypertension, not a primary hypertension. No, it should be a secondary hypertension. Reason why they have given this question to you. Okay, sometimes they might give you a question regarding the essential hypertension as well, the primary hypertension as well, but not necessarily and not every time. So they're saying now regarding the hypertension secondary causes here in Bangladesh, if you are asked what is the number one cause regarding the secondary hypertension, then of course we will say the renal issue, like the CKD or the GN. I mean CKD. Okay, but over there in UK, even in MRCP exam, if you are asked what is the commonest cause of hypertension, I mean what is the commonest cause of the secondary hypertension, the answer will be hyperaldosteronism. Primary, I mean the Cone syndrome. Must. Okay. So if you are asked what is the commonest cause of hypertension over there in UK, so this is the primary hyperaldosteronism. Might be due to cones or other than cones, but usually cones. I mean primary hyperaldosteronism. Okay, due to any other reasons. So this is the single most common cause of secondary hypertension. Again, I'm saying. So what are the other causes? So if you're going to consider any renal causes, if you're going to any renal causes, then the causes are GN, glomerulonephritis, might be case of even the APN, acute pyelonephritis, might be a case of ADPKD, I mean the adult polycystic kidney disease, might be a case of the renal artery stenosis. So now let me give you some idea. Like if the patient is having GN features, I mean glomerulonephritis features, so you have to look for the urinary. What is the protein level? What is the RBC level? Okay, so in urine you are going to check the urinary protein, the urinary blood. So that will give you idea regarding picking the diagnosis of GN. Of course, you need to search for the other features like any recent or concurrent history of throat or chest infection or skin infection that the patient is having or not. Any sort of known features of vasculitis present or not. You know, in oesogenous granulomatosis, the patient might develop RPGN, rapidly progressive glomerulonephritis. Okay, in oesogenous granulomatosis. So that is one type of GN. So in PN, pyelonephritis, you know, renal angle tenderness should be there. Renal angle tenderness should be there. In adult polycystic kidney disease, the most common regarding the MRCP exam, the patient should have some. Right. So, but in MRCP exam, part 1 exam, you cannot do the bilateral test. So they will give you some idea. Why? What is that? The patient has some bilateral flank fullness, or the patient flank fullness. Okay, the patient is having bilateral flank fullness, or the patient feels that his tummy is more heavy or heavier than the previous time. Okay, so this is not the ascites. This is the mass lesion due to ADPKD.
But it can easily be mistaken for an aside or something.
Yeah, bilateral flank fullness. I have seen so many candidates, they're saying this is ascites. Because unless you are doing the ballot test, you cannot explain. একদম হ্যাঁ, তখন ঝামেলায় পড়বে। পড়ে তো তাই, মানে পেসেস এটাই হয়। আপনি দেখবেন আপনি বের হয়ে এসে বলতেছেন আমার কেস তো সিএলডি পড়ছে, আরেকজন বলতেছে আমি তো এডিপিকেডি বলে আসছি। হবে এসএনটা দিছে তো ডিএসইউ অ্যাপ্লাই করছে আবার, বুঝছেন? সো এখন দিবে, BSMO কে দিবে, BCPS কে দিবে, আর তো এবার কে দিয়ে ফেলছে। Anyway, so this is the GM presentation, API and the APM presentation. That and ADPKD there is bilateral flank fullness. Another thing is that patient is having hypertension. The third thing, what you need to know, the patient might develop hematuria in ADPKD. Okay, that is highly important. So in ADPKD, the patient might develop hematuria. The fourth thing, the patient might have a history of stroke, hemorrhagic stroke in previous time. Can you tell me what is the reason behind this? Why the patient is having hemorrhagic stroke in this young age? Because this is due to ruptured Berry's aneurysm. In ADPKD, and particularly in the exam cases, every patient almost with ADPKD is having Berry's aneurysm. Just to justify your depth of knowledge. Okay, not necessarily in practical life you will get this and this, but in exam purpose, patient with ADPKD will have history of ruptured Berry aneurysm, or the father of the patient or any relative of the patient will have this sort of history. Now remember, even renal artery stenosis might come up with secondary hypertension. So what's the difference between these and this? In renal artery stenosis, if you're going to treat the patient with ACE inhibitor, then there is worsening of the situation. There is flank or flash pulmonary edema. The patient will develop flash pulmonary edema. So if you do think they're saying the patient is a known case of hypertension, now it's uncontrolled, we have initiated the ACE inhibitor, and just after ACE inhibitor, after 2 days, the patient develops severe short of breath, and on evaluation it's found that the patient is having pulmonary edema. What's that? This is case of renal artery stenosis. Yes, renal artery stenosis. Okay, so in renal artery stenosis, always remember pulmonary edema, pulmonary edema, pulmonary edema, more aggravated on ACE inhibitor. So here you can never prescribe ACE inhibitor. Another important clue I can give you, that is usually in exam situation in renal artery stenosis, the potassium level is lower than the average level. Okay, I'm not saying that lower than the even the normal, but in lower range, the potassium will be in lower range. Okay, in renal artery stenosis. And other endocrine disorders like the pheochromocytoma, like the Cushing syndrome, like the Liddle syndrome. Now let me give you some idea regarding the pheochromocytoma. I have already discussed regarding the pheochromocytoma, and that is uploaded in our FB page or in our YouTube channel as well. But as pheochromocytoma is one of the important topics that you will get question from, so I am going to discuss regarding this thing as well. Pheochromocytoma is something like that. It's producing some essential or some acute hormones like the adrenaline or adrenaline. Okay, so it causes some sort of high level of blood pressure. So what it happens when the pheochroma, I mean the oma, I mean the tumor is releasing this sort of hormones, then you are getting high blood pressure. Whenever they are not releasing any sort of hormone, ultimately your blood pressure is going down too much low, not even normal, due to the compensation, too much lower. Okay, reason why in pheochromocytoma you're having very low level of blood pressure, even very high level of blood pressure. Okay, another thing by which you can make the diagnosis of pheochromocytoma is the palpitation, I mean the racing pacing of heart. Another thing by which you can make the diagnosis of pheochromocytoma, that is the history of the weight loss. Another thing, that is the history of the anxiety, or or the repeated history of panic attack. Another thing, their history of sweating. Now let me give you another potential mark. What's that? All the features what I have discussed right now, they actually match with the features of thyrotoxicosis as well. So before picking the diagnosis of the pheochromocytoma, try to exclude whether this is a case of thyrotoxicosis or not. Okay, be very, very careful. Okay, but after reading through the scenario, it will be very easy for you, so don't worry. Okay, so now Cushing is an endocrine pathology, we all know that. Okay, so Cushing even can cause secondary hypertension. Remember, Cushing disease, Cushing syndrome, even secondary Cushing, all can present with hypertension. Okay, so if a patient has taken steroid for a long time, it's your duty to check the blood pressure, to check the RPS. Okay, this is a must question in MRCP exam. It's your duty to check the blood pressure, to check the RPS if the patient has long history of taking any steroid medication. Then the Liddle syndrome, I will upload a new video regarding the Liddle, Gentleman and Barker syndrome. So don't worry about that. We have to discuss more and more about this because this is a tough topic. Another thing, there is a congenital adrenal hyperplasia. By excluding whether the patient is having any hirsutism or not, you can make the diagnosis of congenital adrenal hyperplasia. Acromegaly, and again another thing, whether there is any frontal bossing or not, any palm sweating or not, okay, any features of carpal tunnel syndrome or weight gain or not, interdental separation, okay, we all know about that in acromegaly what it happens, okay, or any kind of visual problem or not. Particularly in the exam scenario, the patient will be having severe headache, severe headache, or the patient will be having bitemporal hemianopia, okay, regarding the acromegaly. Okay, I'm saying this, okay, so please mark my word. And the other thing might be in a chronic NSAID may come up with the features of hypertension, as well as in here in case of OCP or steroids, myoinhibitors, or the leflunomide, very important medication, the leflunomide. Another medication you should write it down right here, that is the cyclosporine. So leflunomide and the cyclosporine. Cyclosporine nose is present here, please write it down. So leflunomide or the cyclosporine may come up with the features of hypertension as well. Now, other features like the pregnancy or the coarctation of the aorta. Usually in MRCP part 1, coarctation of aorta isn't our case. In MRCP part 2, this is important, but in MRCP part 1, coarctation of the or COA isn't our case. Actually, coarctation, if you are getting any question regarding the coarctation of aorta, suppose you're going to get any question regarding the COA, so the patient should be a case of Turner syndrome for the exam purpose. So the patient should be a case of Turner syndrome. So unless otherwise the patient is a known case of Turner, don't try to pick the diagnosis of the COA. Okay, don't try to jump on it. What about the pregnancy? Well, you must know that just at the starting moment of the pregnancy, our blood pressure usually drops. Okay, so in first trimester, what you usually see, the blood pressure is lower than the normal. I mean that it drops. Okay, so suppose a pregnant woman who is pregnant for the last 2 months, but her BP is higher. So do you think this is a pregnancy induced hypertension or existing hypertension? Yes, and this is the commonest question from this. So this is a essential hypertension. I mean the existing. They don't call it the existing, rather they call it the essential hypertension. I mean this is a essential hypertension, not the pregnancy induced secondary hypertension.
So basically, they will give me a history of having hypertension even before being pregnant.
No, they will give only this data. That the patient is they will say the patient didn't check the blood pressure before the pregnancy. না চেক করে নাই, ও বলবে যে জানে না, এটাই দিবে, দিলে তো আপনি বুঝেই ফেলবেন যে এটা প্রি এক্সিস্টিং হাইপারটেনশন. সো দে উইল সে দ্য পেশেন্ট ইজ হ্যাভিং হাই ব্লাড প্রেশার, right now at this moment, and there is no previous record of hypertension. The patient never checked any BP in previous time, and this is the first trimester and the second month. Or the essential, right? Yes. So how you will evaluate or how you will differentiate in between this? So usually in first trimester the blood pressure drops, and on the second or third trimester it comes to normal level, not the raise, comes to normal level. If it's raising more and more, so this is hypertension due to pregnancy. So then we are calling it the pregnancy induced hypertension. Okay. But in what about the first trimester? In regarding the first trimester, of course there should be low blood pressure. As I said, it drops in first trimester. But as in your case, the blood pressure is higher from the first trimester. It does mean the patient is already having pre-existing essential hypertension. Reason why the blood pressure is higher here in this first trimester, where it was supposed to be lower. Okay. So this is how we need to evaluate, and this is a very common question. And the way I have told the scenario to you guys, and you'll be given the scenario in this way. Now, what about the hypertension and the diagnosis issue? Well, we shouldn't tell someone that he or she is having hypertension just by the first instance or the first presentation. So we need to classify the hypertension in 2 stages, whether this is a pre-hypertension, whether this is a grade 1, grade 2, or grade 3, or this is a hypertensive crisis, hypertensive emergency, hypertensive urgency, or malignant hypertension. Okay, so there are so many misnomer as well, so many terms as we know. Anyways, if you think the patient is a fast case, that coming up with the hypertension, first, the main thing what we need to exclude, that is whether this is a case of white coat hypertension or not. Okay? Real. Exactly. In MRCP exam, the most common cause regarding the white coat hypertension, other than having any pathology, is white coat hypertension. Okay, so always be careful regarding this one as well. So of course you need to check it out that whether the patient is having white coat hypertension or not. So after that, you can go for these blood pressure monitoring issues. What are those? Like the ABPM, we call it the ambulatory blood pressure monitoring, or the home blood pressure monitoring. Okay. So there are some controversy regarding this blood pressure monitoring, but they are saying that minimum for the 7 days, the patient took some blood pressure record at least 2 to 3 times per day. Then you doctor, you should make a average after assessing these figures. So here you can see the stage 1 hypertension. We'll say the patient is having stage 1 hypertension when the blood pressure systolic is more than 140 and diastolic is more than 90. And subsequent ambulatory blood pressure monitoring daytime average is more than 135/85. আসলে এটা নিয়ে কন্ট্রোভার্সি আছে, মানে আমরা জানতাম, মানে we used to know that the manual method of the sphygmomanometer, that is the authentic method to check the blood pressure. But even after coming to NICVD, our right now at this moment, our mentors, they are saying that the digital device is more authentic. So এটা নিয়ে আমিও জানি না কোনটা more authentic. হ্যাঁ, এটা নিয়ে কন্ট্রোভার্সি আছে।
কারণ আমি শুনছি যে মেশিনেরটা নাকি 20-40 পর্যন্ত
ভ্যারি করে, আসলে ভ্যারি করে, আসলে তো পাইসিও ভ্যারি করে, কিন্তু স্যাররা বলেন এখন কার্ডিওলজিস্টটা যদি বলে এটা, তখন তো আসলে ডিফিকাল্ট, খুব ভেরি ডিফিকাল্ট। বাট ম্যানুয়ালি করতে হবে, কারণ পরীক্ষাতে ম্যানুয়ালি করা লাগে। ইয়া তো এমনি অথেন্টিক না, আপনার যে কাপ ডিভাইস লাগায় এখানে এনআইভিপি যেটা আইসিইউ তে লাগানো থাকে, ওটা তো এমনি অথেন্টিক না, ওটা তো সবসময় ভ্যারি করে। ওয়েল, সো what is the stage 2 hypertension? When the blood pressure is more than 160 and the diastolic is more than 100. What about the severe? When the blood pressure grade systolic is more than 180 and the diastolic is more than 110. And you need to encounter all these three. How? Let me give you the idea. Okay. So diagnosing a case of hypertension, whenever you're going to diagnose a case of the hypertension, you need to check the hypertension, and of course you need to check in both hands, and after keeping the patient in a calm condition. Okay. So they're saying NICE suggests offering ambulatory blood pressure monitoring or home blood pressure monitoring to any patient with a blood pressure of 140 to 90. So now you can see any patient coming up with the features of the grade 1 hypertension, you cannot prescribe medication at once. Rather, first you need to assess this patient after checking the ambulatory blood pressure monitoring or home blood pressure monitoring, then you can prescribe. Now you can ask me, or you can tell me, doctor, the patient is having grade 1 hypertension, so we can, so shouldn't we prescribe any medication? No, the answer is simply no. Again, you are saying, doctor, the patient is having grade 1 hypertension, shouldn't we prescribe any medication? Then the answer will be changed, and I will say, yeah, yes, you should prescribe. So what is the differentiating point? What is the fallacy here? In grade 1 hypertension, you will prescribe only the medication, or you prescribe the medication only whenever the patient is having any other features of target organ damage. Okay, any other features of target organ, I mean any retinopathy, any nephropathy, any neuropathy, something like that, any cardiac issues. So if there is grade 1 hypertension with any TOD, when target organ damage, you can go for antihypertensive medication. No target organ damage in grade 1 hypertension, no, we cannot prescribe any medication, just lifestyle modification and observed. Okay, so this is the main thing, and this is the must thing, of course you need to check for. And in every case of hypertension, must, of course you need to check, that is why you need to check the fundoscope result. Okay, so whether there is any kind of retinopathy or not. Okay, so like might be case of flame shaped hemorrhage, most common in hypertensive, and the arteriovenous nipping, arteriovenous nipping and silver wiring. This is the most three common thing in hypertension retinopathy. What I've said earlier, arteriovenous nipping, or the silver wiring, and later the flame shaped hemorrhage. And in more advanced case, there might be some papilledema. Okay, these four. This four you need to know regarding the hypertensive retinopathy. So, and NICE also recommend referral if a pheochromocytoma is suspected. So, if you think the patient is having any fluctuating blood pressure, headache with palpitation, pallor, and diaphoresis, then of course you need to send the patient to an endocrinologist for the evaluation of the pheochromocytoma. Now, let me give you another excellent idea regarding the excluding criteria of pheochromocytoma, that is the headache. In hyperthyroidism or in thyrotoxicosis, there is no headache. But in thyrotoxicosis, there is also palpitations, there is also diaphoresis, there is also exophthalmos or pallor. Even a patient might develop hypotension and hypertension both together in thyroid issues. So now, ambulatory blood pressure monitoring, at least 2 measures per hour during the person's usual working hours. For example, between 8 to 22, use the average value of at least 14 measurements. And what I've said it, you have to take 2 measurements for 7 days. So 2 will be multiplied by 7 equal to 14. So that's the thing. So home blood pressure monitoring, again, just give a reading. And ambulatory blood pressure monitoring or home blood pressure monitoring, if you think that they are more than 35 by 85, so this is grade 1 hypertension. Will you treat the patient? Yeah. Treat if less than 80 years of the age and any of the following apply. If the patient is having TOD, I mean target organ damage, or patient is having established cardiovascular disease or a renal disease, again giving the evidence of TOD, or the patient is having diabetes or 10-year cardiovascular risk equivalent to 20% or greater. So these are the cases, these are the indication cases where you can prescribe medication in a patient with grade 1 hypertension. And this is a must question, this is a 5-star talk. What about the stage 2? Irrespective, regardless the TOD, you can prescribe the or offer the medication to the patient. What are the medication? Okay, we'll discuss later on. So, okay, let me give you the idea right now at this moment. Okay, so now listen to me very carefully. Whenever it's your time to prescribe antihypertensive, you will assess 3 things. You will assess 3 things. Number 1, what is the age of the patient? Okay, what is number 1? What is the age of the patient? Number 2, what is the sex? Sorry, not the sex. What is the age of the patient? Oh, sorry, whether the patient is diabetic or not. Number 2, whether the patient is diabetic or not. And number 3, what is the race of the patient? So now give me the 3. Number 1, age. Number 2, diabetic or not. Number 3, race. Number 1, as I said, the age of the patient. The landmark is 55. Okay, landmark is 55. Landmark is 55. Then diabetic, and race that is African or non-African. Okay, African or non-African. So now jump on to the number 1. There is the age. If the patient is more than 55, if the patient is more than 55, we all know that in elderly renin activity is already low, so we cannot modify the renin modulation or renin pathway. Reason why? More than 55, we are going to prescribe the patient with calcium channel blocker. So more than 55, calcium channel blocker. Less than 55, ACE inhibitors. Okay. So if the patient is 45 years old, ACE inhibitor will be the first thing. If the patient is 65 years old, calcium channel blocker like amlodipine, cilnidipine, medication like these and these. Okay. So more than 55, calcium channel blocker. Less than 55, there is the ACE inhibitor. Number 2, whether the patient is having diabetes or not. If the patient is diabetic, if the patient is already known case of diabetic, so duty to give anti-hypertensive medication like ACE inhibitor. So diabetic means ACE inhibitor for the exam purpose, not in a case of practical life. So ACE inhibitor, regardless of the age. Okay, regardless of the age here. So now the patient is diabetic, but the age is 70. So what? ACE inhibitor, as the patient is diabetic. Okay, okay. Now the third one is the race. Actually, in African or Afro-Caribbean group, ACE inhibitor has no valuable role. Reason why? African or Negroid, it does mean we'll go with calcium channel blocker. Okay, calcium channel blocker, whatever the age is, calcium channel blocker. Okay, so the age is 35, but the patient is from Africa. What will be the medication? calcium channel blocker. Yeah, this is the real case, real exam case. Now we got my point. So now you have started with, suppose you have started with the ACE inhibitor, it's not working. So then don't increase the dose of the ACE inhibitor, rather add polypharmacy. Try to prescribe polypharmacy. Polypharmacy is justified here in case of hypertension and diabetes. Okay, so if the patient is not working with ACE inhibitor, we can add calcium channel blocker. If the patient is having calcium channel blocker and is not controlled, we can add ACE inhibitor. So vice versa. So it's not working. Then we'll add the diuretics here, not the beta blocker. So at first we have used A and C, ACE inhibitor and the calcium channel blocker. Right now we're using the D, ACD, not the ABCD. I mean B is absent here. So now we are using the D, I mean the diuretics. Again, after using these three, the patient is not responding that much. I mean, is not responding good enough. So then what are we going to do? Then we are going to increase the dose of the diuretics. Okay, then we are going to increase the dose of diuretics. Again, not working properly. So this is a resistant hypertension. Okay, so this is a resistant hypertension. Okay, resistant hypertension. After that, you can consider any other fourth or fifth medication, like might be any kind of alpha channel blocker.
If increasing diuretics don't work, then what do we give?
What then the other medication like these and these. What are those medication? Might be you are giving some alpha blocker, prazosin or alpha pres, alpha lock, like this one. So you can prescribe the alpha blocker. You can go for any other medication. What are those medication? Like maybe methyl dopa. Basically, methyl dopa is a medication we use only in pregnancy. Here in Bangladesh, in our guideline, it said that during pregnancy we should use calcium channel blocker, not the.
Many nephrologists go ahead and use alpha prescription.
Why? Can you tell me that why they are using? Why directly they are prescribing alpha pres?
Because it's safer on the
Yeah, because particularly on the kidney patients, sometimes it is very difficult to continue with ACE inhibitor because high level of serum creatinine.
So if a person has history of kidney disease, shouldn't I just prescribe alpha pres or pantopres?
No,
Pregnant.
no. If the patient is already known case of CKD, even on dialysis, at first the first medication what you need to do prescribe, that is the ACE inhibitor, right? ACE inhibitor, because recent study says that is actually it will alter your mortality, improve your mortality, and it's highly necessary for the kidney patients as well. So ACE inhibitor the first thing, not working, then ACE inhibitor. Again not working, then you can consider beta blocker. Okay, sometimes even diuretics not working, then you can prescribe alpha blocker like the prazosin, something like that. Even not working, then you can prescribe the third one here, like the clonidine medication by the nephrologist, because most of the time the resistant hypertension or the malignant hypertension, they are the doctors who are dealing with. So clonidine. So we are saying it that C for clonidine, and we will add A and R. So CAR, this is the CAR theory, Gadi theory. CAR theory. What's that? CAR does mean CAR. It does mean C for clonidine, A for adreno, R for receptor. So CAR, it does mean clonidine adreno receptor. Okay, clonidine adreno receptor. So we are calling it the CAR. Okay, so adreno receptor. So the antihypertensive is mediated through the stimulating the alpha 2 adrenoreceptor in the vasomotor center. What about the moxonidine? Okay, when everything is going to fail, then you can go with the moxonidine and methyl dopa, particularly during the pregnancy. But here in Bangladesh, currently we don't prescribe methyl dopa, rather we are prescribing the calcium channel blocker. Okay, simply calcium channel blocker, because in our guideline, methyl dopa has been changed to calcium channel blocker. Now, what about the diabetes mellitus and hypertension mellitus? As I've said it, if you think the patient is having hypertension and diabetes both together, then ACE inhibitor is the first thing. You can hold the chance of proteinuria with this patient. Okay, so this is the main thing. I mean, diabetic nephropathy, you can control the diabetic nephropathy. What about the malignant hypertension? Malignant hypertension is such a condition when there is a severe hypertension, like the systolic hypertension more than 200 and the diastolic hypertension is more than 130. So this is the malignant hypertension. Malignant hypertension might be possible even in essential and secondary, both cases. Why it's dangerous? Why we are very much worried regarding the malignant hypertension? Because you know that in malignant hypertension, three things are very common. Three things very common. Hypertension, yes, retinopathy and encephalopathy both together you can say malignant or hypertensive encephalopathy. Okay, hypertensive encephalopathy. So there might be hypertensive encephalopathy, number one. Excellent. I really appreciate your concern. So first of all, hypertensive encephalopathy over there in brain. So what will be the features of the eye? Papilledema. Okay, papilledema. Okay, so what will be the features of the heart? There might be failure, hypertensive heart failure. Okay, hypertensive heart failure. Even in brain, there might be some features of cerebral edema due to stroke, hemorrhagic stroke. Okay, cerebral edema due to hemorrhagic stroke. So always know these things as well. What will be the nose or nasal findings? Might be epistaxis. Okay, might be epistaxis. What will be the renal findings? Might be hematuria. Might be hematuria at first in hypertensive, malignant hypertension. After that, you can consider proteinuria or something like that. Okay, why I'm saying this? Because in malignant hypertension, the vessels are going to be lost. The vessels are going to be destroyed and lost. Why? It will cause fibrinoid necrosis of the vessels. This malignant hypertension. So ultimately, eventually, the patient will develop this and this. So encephalopathy is the most common thing. And hypertension, we must keep it in mind. So when the patient will present to you with these features, the patient might be presenting with the features of stroke, or even might be presenting with the features of seizure. Right. So high BP might come up with the features of hemiparesis. Even high BP might come up with the features of seizure disorder. Hemiparesis even might come up with the features of hypertension. Hypertensive emergency might be presented as a case of heart failure due to hypertensive, heart failure, hypertensive heart failure. So try to rule out all those things together, okay? And papilledema, never forget this one. Papilledema, never forget this one. So now, how will you manage the case? Basically, we have to reduce the pressure, but the diastolic, we shouldn't reduce the diastolic not lower than 100 millimeter mercury within the next 24 hours. We have to give the patient proper bed rest, and most patients, the oral therapy is atenolol. In severe encephalopathic, sodium nitroprusside hydrolabetalol. Actually, most patients, they are saying in most patients they are treating the patient with atenolol, right? They are treating with the atenolol, but as I'm saying, MRCP, there are so many things that is highly controversial with MRCP. Like here in Bangladesh, if you're going to treat the patient with malignant hypertension, we try to use IV Lavicard or labetalol if you're working in the medical college hospital or something like in tertiary setting. Or if you're working in the ICU, we're treating the patient with IV GTN. IV GTN. Never ever with atenolol. But in MRCP exam, if you're not picking the answer of the atenolol, you are in danger. Because this is the first medication what you need to try with. Okay, this is the controversial thing. Like in your what day-to-day ward life, your sir has asked you what is the blood pressure, BP. You have said, sir, the blood pressure or the BP on presentation was 200 by 100 to 20. Yes, sir, your sir now will ask you, so what have you done? Sir, I've given atenolol to the patient. Sir will be looking at you like this way. What the hell you're talking, doctor? Okay, because it's not practiced here in our country. So this is the difference. This is the massive difference, I think, in between this and this. Now the Turner syndrome, as I've said, Turner syndrome has some cardiology issues. So the most common thing regarding that Turner syndrome, what you need to know, that is the what's that? Bicuspid aortic valve, this one, the bicuspid aortic valve and the coarctation of the aorta, as I said earlier in my class today, right? In coarctation of the patient should have a case of Turner syndrome. So Turner syndrome should be a case of the bicuspid aortic valve, coarctation of all the other features, you all know all the other features, but never forget the main two, bicuspid aortic valve and coarctation of the number two is primary amenorrhea. Okay, if the patient is not having primary amenorrhea, that's not a case of Turner, at least for your exam. Okay, at least not a case of primary a case of Turner in your exam as well. Okay, now let me give you a very, very important question of MRCP part 1, and I'm sure about that this is the first time you're having this question from me as well. Now look here, in Turner syndrome, the karyotyping is 45x0, right? 45x0 in Turner syndrome. I mean, the patient has not the opposite X, or the as this is a female case, so shouldn't have a Y. Turner is absolutely for the female. Okay, for the male Turner, we call it the Noonan syndrome, not the Turner. If any male patient is having Turner, then we call it the Noonan syndrome, or the male Turner syndrome. Okay, Noonan or male Turner syndrome. Anyways, forget about that. Well, now let me know. Do you guys know about the hemophilia? That is an X-linked recessive disorder, right? X-linked recessive disorder, right? X-linked recessive. So do you think that females will be sufferer regarding the XLR? I mean, X-linked recessive disorder, right? We all know that in X-linked recessive disorder, male are the sufferer, female are the carriers, right? Yes, absolutely right. Do you know why? Because, now let me give you the idea what happens.
Females have two genes, XX.
Like in this way. Suppose what happens in here, like in these women, and suppose this is the male patient, okay? Yeah. Suppose this male patient is having this defective gene of the hemophilia. So we're calling it the H. And we all know hemophilia is X-linked recessive. X-linked recessive. As this is not dominant, so we are not writing the capital letter. Okay? So this is why we have used the small letter here. So this male will be sufferer. Why? The patient has got a recessive gene and it's causing the patient to have a disease like hemophilia. That's fine. Suppose this patient, oh, by the way, as this is a recessive gene, so of course there should be a dominant gene.
So females having the dominant gene.
Exactly. So females might have a gene like this one, recessive gene, but actually the female and normal female, they also have a dominant normal gene. As the normal gene is dominant, so the female will express the normal gene. I mean, the female will not actually express the disease, rather he will transmit the disease to the offspring, particularly in the male one, right? Now look at here. What happens if the female is like this one, I mean, both of the genes are having recessive, then this female, yes, this
rare,
very rare, isn't it? But what is common? This one. Suppose this female has only 45, I mean only one X, and somehow this X is containing the recessive, and the opposite is totally absent. So there is no question regarding the presence of the dominant one.
So she will have
Yes. So this is the question for you guys. Okay. There will be some features like this. The patient is short stature, patient wave neck, the patient has bicuspid aortic valve, patient has high blood pressure, known case of coarctation of aorta, patient has not mistreating for a long time. Huh? And now this patient has severe bleeding problem. So what is your diagnosis? This is the case of hemophilia. So you will be very astonished, oh, how I can make a diagnosis in a female. But yeah, in this female it's possible because this female is suffering from Turner syndrome as well. So in Turner syndrome, X-linked recessive disorders are possible. Not common, but possible. Okay, so remember this thing. That was my question in MRCP part one. Okay, that was my question in MRCP part one, but I couldn't answer it. Okay, I got to know this after time. হ্যাঁ আমি বুঝতে পারি না তো, পরে না আমি বের হয়ে আমার কলিগদের জিজ্ঞেস করছি, ওরা বলতেছে এটা খুব কমন কোশ্চেন, মানে রিকলস জানাটা এই জন্য খুব হাইলি ইম্পর্টেন্ট টু নো দ্য রিকলস। কারণ রিকলসে আপনাকে মানে হোয়াট ইউ নিড টু নো, ইউ নিড টু নো অল দ্য রেয়ার কোশ্চেন্স। ওকে, ইউ নিড টু অল দ্য রেয়ার কোশ্চেন্স। আমরা রিকলে কিন্তু কমন কোশ্চেনগুলো বেশি বলি না, কারণ ওটা তো আপনি এমনিও পড়ে পারবেন। So all the rare questions I try to reveal, all the rare question, all the atypical. This is the beauty of the class, and this is why you need to be attentive and you need to present in this class. Okay, so ওছাড়া কিছুই নাই, ক্লাসে যে খুব বেশি কিছু শিখে আমরা, that's not like that, but in class you need to be present over here. Okay, so this is the male Turner syndrome, as we have discussed regarding these things. Okay, so now jump on to the next one. Coarctation of aorta, again a very important talk for MRC part 2, not for MRC part 1. Basically they try to give us the association. I mean, what the who are at high risk of developing COA. So now we can see patient with Berry's aneurysm, patient with bicuspid aortic valve, I mean the Turner syndrome patient, again a neurofibromatosis. Now isolated systolic hypertension, simply a very simple question, what would be the medication of choice here? The calcium channel blocker. So initially, listen to me very carefully. Drugs such as the thiazides were recommended as the first line agents. These approaches contraindicated by the NICE guidelines, which recommended treating the isolated systolic hypertension in the same establishment as standard hypertension. But even in our country, sometimes whenever the MO visits us, they try to give us these data, old data, that thiazide diuretics is superior isolated systolic hypertension, but no, not in MRCP cases, pardon exam. Hypertension in pregnancy, we have already discussed regarding these things earlier, so just give a reading. Preeclampsia, 2-star topic, the graduation topic, I must say. So this is the management plan, we have already discussed about it. What the patient, I have said it in step 1, you have to look for the age limit, whether the patient is less than 15 or more than 15. Less than 15 is inhibitor, more than 15 go with calcium channel blocker, and of course check the diabetes status of the patient. Okay, and step 4, please give a 5-star here. Step 4 treatment, give a 5-star here. This is a very important question, how you will add the or increase the dose of the diuretics. This is how. If the potassium level is less than 4.5, I can add spironolactone. More than 5, I still I have to go with the thiazide diuretics. So now this is the Takayasu arteritis. That was the last topic of our today's session. So now you can see that in Takayasu arteritis, what I have discussed today, the patient will be having some constitutional issues like the fever, malaise, or headache. And of course, as we are calling it, the pulseless arteritis or pulseless vasculitis. So there will be some unequal blood pressure or unequal pulse in the hands, and carotid bruit. You must auscultate the carotid and the precordium, and the patient might be having intermittent claudication, and in precordium you might appreciate a murmur of early diastolic murmur. That is due to the aortic regurgitation. And what is associated here with? There is the renal artery stenosis, reason why the patient might come up with the high blood pressure. And how will you manage the case? Simply by steroid. And remember, if you have been given a case of young onset stroke, I mean hemiparesis, okay, but age is very young. So as the case is regarding the hemiparesis, so what do you usually think? It might be a case of a stroke. Okay, right-sided hemiparesis. So what's the reason behind this? Might be a left-sided stroke. But if this is a young onset, that shouldn't be a stroke at first. Might be a ICSOL, number 1, space occupying lesion, maybe a tumor or something like that. So a space occupying lesion you must exclude before making a diagnosis of stroke, number 1. Number 2, as this is a young onset, so this is more common and more important in exam scenario. What's that? That is the demyelination, like multiple sclerosis. Okay. So, and after that stroke. So in elderly patient, if I am saying what are the differentials of hemiparesis in elderly patient, then a stroke, ICSOL, demyelination. In younger patient, then demyelination, ICSOL, then a stroke, then stroke. Suppose no demyelination, suppose what is saying, no ICSOL, but the patient is very young and you have got a stroke, you have got a case of a stroke. Now you have to read out why the patient has got a stroke in these age, why the patient has developed ischemic or hemorrhagic stroke in these age. If hemorrhagic, might be Berry aneurysm, might be ADPKD, polycystic kidney disease, might be malignant hypertension, something like in this group. If ischemic stroke, then you have to patient. Recently, we have lost one of our cousin due to malignant hypertension.
How? Young. How? Did he have any renal issue?
Yes. ADPKD with Berry aneurysm. Okay, then so তখন মানে we just lost. হ্যাঁ, তো একটা মানে এটাই বললাম যে আসলে কিন্তু খুব দূরে যেতে হয় না, কাছাকাছির মধ্যে কিন্তু অনেক সময় সামটাইমস পড়ে যায়, কিন্তু ভাবি না আমরা তো বাসায় এইভাবে we do not think actually in that way. হ্যাঁ, the way we usually think in exhibition scenario. তো ইটস কমন। আর যেটা বলতে চাচ্ছি যে young stroke, if it's ischemic stroke, if it's ischemic stroke and it's young, number one thing you need to exclude whether embolism, right? Whether there is any kind of left atrial fibrillation or not. Any embolism issue or not. Number one. Number two, any DVT or pulmonary embolism. These two. Number three, must. You must know because this was the question in 2023. All the diets. That is the Takayasu arteritis. Okay, yoga stroke. So patient with Takayasu arteritis may come up with the features of simply young stroke. Okay, hemiparesis. Okay, yeah, hemiparesis. So remember all these things together. So in a young stroke, is it necessary to see the pulse symmetry?
In young patient.
Yeah. Yes.
Yes. Because
Yes.
there might be an embolism, so there might be a difference in.
No, not really embolism due to Takayasu arteritis. In Takayasu arteritis, there will be some pulseless activity. Yeah, vasculitis. Okay. Vasculitis, there is not, suppose the patient is not having any pulse in the right hand, but the left hand is having normal pulse. So pulseless activity, you need to see whether there is any sort of pulseless activity or not. Okay. In young stroke, do you need to see the pulse for any other reason? Yes. Whether the patient is having atrial fibrillation or not. Do you need to see the precordium? Yes. I want to check whether there is any murmur like MS, mitral stenosis, that is highly associated with stroke. Huh? Okay, you need to see the precordium as well. Do you need to see the carotid area in your stroke? Yes, I will see the carotid fluid. Yeah.
In relation with JVP?
Not really. Not really. JVP is really associated with the high pressure of pulmonary vessels. I mean pulmonary hypertension. Okay, not stroke. Because JVP is associated with the only pulmonary circulation, not the systemic circulation. There shouldn't be a case of a stroke. Stroke, if it's all about a stroke, of course it should be involved with the systemic circulation, not with the pulmonary circulation. Okay, now let me give you another tough question. The patient has got DVT, so the thrombus is in the vein, DVT, deep vein thrombosis, now came up with the features of stroke, and the artery here is involved, that is the medial cerebral artery. So embolus was in the vein, now it's in the artery. So how is that possible? How is that possible? Anyone? Try. So now you can see from the vein circulation, now the thrombus is in the arterial circulation, isn't it?
Yeah.
So of course might be there's some sort of anomaly in the heart that is connecting in between the right side or the left side. Might be patent from anomaly. Yes, and this is the most common thing, or even the simple ASD or the VSD with shunt reversal. Why the thrombus has now dislodged from the vein side to the arterial side. The most common questions in MRCP pattern, that is the pattern from an ovally. But also be ready for the other differentials as well. Yes, anything? Anyone?
Epstein.
Okay. Sorry, sir, I cannot hear you.
Epstein anomaly.
Yeah.
Epstein.
So, okay, so we'll start with aortic dissection from the next class, because this is a different topic and also very important topic. But as I'm saying that cardiology is one of the hot topic, and cardiology is one of the most tough or toughest topic in MRCP part 1, part 2, even in PACES. So please take 100% best possible preparation from cardiology, and never ever forget to solve the questions from the past test, question from the on exam, and of course the question from the past medicine. You will get the questions here. Okay, at the last of the chapters, you'll get the questions, and don't take too much time while you're going to solve the questions. Okay. Okay. Anyhow, we have jumped into the question number 267, and you can see here the answer is acute pericarditis, and you can see here the PR depression. I think this is the most specific findings of the acute pericarditis that has been asked to us, the PR depression. And whatever the tropi, high level of tropi, as I've said it, tropi might be false positive even in pericarditis, even in CPR, cardiopulmonary resuscitation, even in pulmonary embolism. So tropi is not a specific thing. Okay, tropi is not a specific. Tropi is simply a overrated thing. NT-proBNP is somehow more specific than the troponin I. NT-proBNP is specific for heart failure. Troponin is specific for heart attack, though we say, but troponin I is not that much specific, because in CKD events, CKD patients also have some high level of tropi than the normal. Okay. So be very careful regarding whenever you are making any sort of diagnosis, or coming into any sort of conclusion, or any sort of decision. Okay, be very careful regarding this and this. You can see here the bisoprolol. I think the question was asked regarding the what are the medications, what are the beta blockers you can choose: bisoprolol, carvedilol, the nebivolol. So never ever skip any question from the past medicine and past test, at least. Okay, at least never ever skip any question from the past medicine and past test, past medicine and past test. But yeah, you also try to solve the question from the on exam, but it's very difficult to solve all the 3 question banks at a time. But it will be a wise decision if you're solving the 3 question banks minimum. It will be a very wise decision, because ultimately you will get to know so many things. Most importantly, PACES will be easier for you. That's the most important beauty of solving all these 3 question banks. And I don't think that you have to fall in danger if you're going with all these 3 question banks and after these notes. And if you're going through the notes, no necessary to go with other books. No necessity. I can give you the guarantee. I can give you the guarantee. So don't worry about that. So do you have any questions? Okay, so if you don't have any question, we can end up the session here. So I hope you enjoyed the class and got to know so many things. So happy learning. Wish you all the best.